The central fingertip skills of microsurgery are extremely simple, and you will learn them quicker than you think and better than you think. But you cannot learn these skills and you cannot use them unless you first pay attention to the preconditions of microsurgical skill that I'm going to talk about now. Whenever I see people getting into trouble in microsurgery, and whenever I get into trouble myself, it isn't because of any innate lack of skill at fingertip level, it's because of lack of preparatory thought, lack of preparatory skill. You can't do this fine work unless, first, you're in the right frame of mind. We're going to talk about that quite a lot. You can't do this work unless you are comfortable. You can't do this work unless you know how to use your hands in the right hand position for fine control and the avoidance of tremor. We'll talk about that. You can't do this work unless you know how to get the microscope into good shape, well adjusted to work for you. And lastly, you can't do this work unless you have good instruments and know how to keep those instruments in good shape. So, in this preparatory talk, we'll cover those 5 seemingly rather different areas, which all have this one thing in common, that they're absolutely essential preconditions for good microsurgical work. And listen up, I beg you, because they are more important than you now perhaps appreciate. Let's talk about psychology first. There are 3 useful things I can tell you about being in the right frame of mind. 2 of them are useful straight away now, and one of them is something you need to keep in your mind for future use. I need to tell you about not overtaxing yourself. I need to tell you about how to avoid desperation, and I need to tell you about the importance of preparedness in the most general sense. The simplest thing about being in the right frame of mind is simply this: do not work for too long at a stretch, especially in the lab when you're doing that hardest thing of all, that's learning new things. If you work hard and attentively for an hour in the lab, you'll become tired. You should become tired, and at the point when you become tired, you should take a break as a definite part of your learning program. If you go on working when you're tired and when you're getting a little fatigued and desperate, the only thing you're learning is, I don't enjoy doing microsurgery. You don't in fact learn anything new or anything better. You just learn that negative bit, which you can well do without. So at the end of an hour, take a scheduled break of 5 or even 10 minutes, and don't feel you're wasting your precious time. You're using it very, very well. The way you'll waste your time is if you stubbornly insist on working right on through the day, getting more and more fatigued and exasperated. That's a bad waste of time. So if one of us mentions to you that you're getting a little tired, however tactfully we say that, please take it as a definite order to stop and break. And by that I don't mean just lean back in your chair and take a couple of deep breaths. I do mean get up, get out of the room, disconnect your mind from whatever you've just been doing, and let your circuits recover and get reconnected before you go back to the work. Clinically, this is important too. Clinically, you can space out your breaks longer, because once you're into clinical operating, you're generally into something that you know what you're doing, or you soon will be at that point. We very often work for 2 hours at a stretch before we take a break, and 2 hours is long enough to accomplish a simple procedure. If it's a long procedure, we think nothing of walking out of the OR, sitting down, relaxing, and switching off for 5 or 10 minutes, and then coming back refreshed and much more efficient. The second important thing to tell you about psychology is a little bit about developing a positive attitude toward difficulty. You'll get into difficulty learning this work, and sometimes you'll get into such difficulties that you'll get the paranoid feeling that the forces of evil are ranged against you on a personal and very deep level. And once that feeling gets a hold of you, you'll quickly go from difficulty to desperation and on to disaster, and the distance between those three is a very close one in microsurgery. What you must learn to do, and I hope you'll use some of your time in the lab to learn this important habit, is when you get into difficulties, stop and think about what those difficulties actually are. They're very seldom great, abstract, mystical things. They're almost always perfectly finite, tangible, mechanical things which you can correct and which you should correct at a very early stage before they get on top of you. The sooner you can spot the fact that you're in difficulty, the sooner you can stop and think about that difficulty and correct it, the sooner you'll be back into good, efficient operating conditions. Let me give you an example. You may get to a point when you're in the middle of an anastomosis and you find that you're in a state of just cumulative desperation, that you're holding your breath, every muscle in your body is aching, and you're hovering on the brink of putting in a disastrous suture, which you know is going to be disastrous, and you know that the very next step, or the next step after that, is going to be the final mess that you make. Now, at that point, you still can retrieve the situation if you stop and think, now, how in the world did I get to this awful situation? You've got to do this in the lab, because you've got to learn this habit of thought in the OR. Now, if you sit back and think, starting from the beginning, about what your difficulties actually are, you will find, for instance, I saw this just the other day, somebody in this situation, that one of the legs of the table is a little short, and the table is wobbling, and has been all morning, and you could very well have corrected it when you first sat down to work. You'll find that your chair is an inch too high, and you've been stooping and giving yourself an uncomfortable body position. And again, you could have corrected that, but you didn't, so that needs to be corrected. You'll find that your work is arranged on the table in such a way that your elbows are hanging loose and you don't have basic stability of your hand position. And once again, if you'd thought about this ahead of time, you could have corrected it, but here it is, it's still part of your big difficulty that you're in. And then coming closer to the work on hand, you'll realize that in fact you didn't put the incision in quite the right place, and your access has been poor all along, and your hemostasis has been rather substandard, so that you've got blood between you and the thing you're trying to work on. It doesn't take much blood to make your work invisible. Added to that, one of the eyepieces on your microscope is slightly out of focus, and you haven't got a proper three-dimensional view. And I can't count these separate points, but perhaps 7 different, quite identifiable things have accumulated to make your job what we call impossible. And there isn't such a thing as impossibility, but there is definitely such a thing as a large number of uncorrected obstacles to success, which by your neglect of preparation, you can allow to get on top of you. Sit back and think about difficulty as soon as you can. Identify the difficulty and correct it, and you'll stay right on top of the job. Now lastly, and this is, like I say, for future reference, when you've done this many times, been into difficulty and thought your way out of it, you'll get such an efficient checklist in your mind of preparatory thoughts and actions that you will one day be able to walk right into a major microsurgical procedure, safe in the knowledge that everything is set up ahead of time to where nothing is really going to go wrong and nothing is going to distract you except the details of the job in hand. That should be your goal if you're going to do any significant amount of microsurgery. That's a long-term goal, and you'll reach it by doing what I've advised you to do. That is to think very constructively about each difficulty that you meet. And think about your microsurgical setup, not just as what you have in front of you on the table or with regard to instruments, but think of your microsurgical surroundings as including also the people around you, the room around you, the space and time and peace of mind available to you. These all are part of your surgical technique. Okay, that's enough about psychology. And the next thing I want to talk about, you might think is also very abstract, and that's comfort. Now, comfort is not, in fact, an abstraction at all. It's not a luxury either. It's an essential in microsurgical work. Comfort is neglected by surgeons in other fields because it's not strictly necessary for success in many other surgical fields. It's considered, indeed, a little effete to insist on being comfortable while you work. Well, in microsurgery it's very different. It only takes a little discomfort to invade quite seriously that part of your mind which is supposed to be concentrating on the job you're doing. And added to that, microsurgery is special in that you're locked into one particular body position. And if that isn't a comfortable position, there's nothing you can do to change it. It gets worse and worse and worse, and you can't move out of that position. And very soon a little discomfort becomes a very, very big one. So let's look at the business of being comfortable in quite a practical way. First, to define comfort and what it is. That's very simple. Comfort is a state of body position in which the minimum number of muscles are working in order to maintain that position. That's what comfort actually is. Now let's see how we achieve that. It starts at floor level. And there's some very important things to remember at floor level every time you sit down to work. You must sit in such a way, particularly with regard to your feet, so that your trunk has good 3-point support. Those 3 points being your seat and your 2 feet. Now, if you looked at this from above, you'd see that what we've got is a triangle here between the feet and the seat, and that's a very stable situation. I don't need to use any muscles to stop my back from rocking backwards and forwards or from side to side. It just maintains itself very comfortably. Now, if I just make a small change like this and put only 1 foot on the ground, then I've only got 2-point support for my trunk, and I can wobble from side to side quite easily. And you'll find that you get quite sore muscles in your trunk after an hour or two just trying to sit still in this position. Still worse, if you cross your legs up underneath you like this, then you've only got 1-point support, and it needs the constant, well-adjusted activity of a whole lot more front and back muscles to keep you upright and to keep you still, so you get even more tired. And worse again, let me just move up to the table here. If you try to work with your legs to the side, twisted right around like that, or if you try to work with your 2 legs spread eagled out here to come round an obstruction, you'll find yourself horribly uncomfortable and tired after a very short time indeed. So, at floor level, this is the position you start in. Now, in some kinds of surgery, that's easy to arrange. In hand surgery, it's not hard at all. You've got a nice table here and space beneath you, and space too for your knees. No point putting your feet there if you can't get your knees there as well. In head and neck surgery, it's a little more difficult because you've got that rather thick table here, and you've also got just down here the pedestal with all the knobs and levers and such like things. And we solve that problem in head and neck surgery by turning the patient round and putting the head on the foot end of the table. That way we have free space. When you're doing the kind of surgery that involves working on the middle part of the trunk, then you are really up against it because you have that enormous obstacle on the floor, which is the central pedestal of the operating table. And you really have to make some enormous adjustments to the patient's position on the table, slide him a long way down the table, put a huge leg extension on the table, even sometimes put a prop underneath that leg extension so the whole thing doesn't capsize. Anything so that you can do this. Don't suffer It isn't smart. It's simply foolish to suffer in terms of body position. Moving now from floor level, let's consider the table in terms of comfort. It's essential to have a very steady table that doesn't move up and down or sideways when you work on it. It's important to have a table which is fairly shallow so that you don't have anything impeding your knees. And it's important to have a table that's wide enough that you can get yourself and your work, and if necessary your assistant's arms, on it and rest your forearms in this fashion. It's no good having a table, and it's no good having a work position which dictates that you work like this with your elbows off the table. That's an absolute no-no. If you have your elbows hanging free, then a whole lot of muscles have to get to work to hold your elbows still. These muscles and these muscles. And if you work like that for any length of time, you'll not only have rather poor control of your hands, but you'll have a sore set of shoulders and a real stiff neck, and that's well worth avoiding. So just have your work set up here, well on the table. You don't need to have your olecranon right on the table, but you do need to have the center of gravity of your forearm on the table, like so. Now the next thing which dictates the comfort of your position is the height of the microscope. Let's bring in this microscope. I don't have it switched on at the moment. That doesn't matter. Once the microscope has been brought into focus on the work you're going to do, the position of the eyepieces tells you where you've got to have your head. And if you don't have your head sitting at just the right height to look down those eyepieces, you're going to be mighty uncomfortable. Now this has a lot to do with the height of your stool. Let's see if I have the height of my stool right. I probably don't. If I sit here and I bring myself to look down the microscope, if I keep my back straight and my neck straight, as I should, then my eyes are that much too high to see comfortably. To look down the microscope, I would have to slump down here and bend my neck in this way, and that's not comfortable, believe me. So I need to put my stool down. Now let's see if that's any better. If I come up to the eyepieces now, I'm in fact just a little low, went half an inch too far. It doesn't sound as if half an inch is a really important adjustment, but it can be. You need to be very particular about this. That's just great. With my back straight and my neck straight, in neutral, relaxed positions, I can come right forward there and look straight down there. Good. Your nurses may think you very picky in the operating room if you ask them to put your stool just half an inch up or half an inch down. But you should ask them to experience a state of microsurgical discomfort for a couple of hours, and then they'll realize they're not really fussing. One last thing about your stool. A microsurgical stool should have feet and not wheels. You don't want something that has a constant temptation to scoot away behind you. It should be very easily adjustable up and down, and if you really want the ultimate, it should be padded like this, but that's not too important. You don't need arms, you don't need footrests, and you don't need a backrest on a microsurgical stool, because those sources of comfort come to you simply from assuming a natural posture. If you need an armrest or a backrest or a footrest, there has to be something basically wrong with your body posture, which you ought to correct. So much for comfort. Don't neglect it. Don't think of it as a luxury. Don't think of it as an add-on. Think of it as a central part of your surgical technique. Something which you would no more start without than you would start without draping and prepping the patient. Get comfortable at the start of a procedure. Say to yourself, now is the time when I do those things which are going to make me comfortable. Don't wait till you're in the middle of the procedure before you say, oh gee, I haven't got a place for my feet to be, or I've got a backache. That's too late. Your power of concentration is already messed up by that time. Do it ahead of time. It's so important. The next really important thing I have to talk about is hand position and the avoidance of tremor. If this is the first time you've done any microsurgical work, you'll be worrying about whether you have a tremor that's going to make your work difficult. Well, if you have a tremor, you're in very good company, because I don't know anybody who doesn't have a tremor. A tremor, after all, is simply random muscular movement in your hand muscles and your forearm muscles, and we all have more or less of that. There isn't really such a thing as a steady hand in microsurgery. You hear about the microsurgeon's magical steady hand. This is a myth. What there is a series of very simple tricks and maneuvers for getting the most stable hand position. And this is what we'll talk about right now. Before showing you what is a good hand position, let me just cover some basic ideas and preconceptions about tremor, things that make it better and things that make it worse. It used to be taught that you mustn't smoke, you mustn't drink, and you mustn't indulge in various other enjoyments if you wanted to be a microsurgeon. Well, most of that isn't true, I'm glad to say. With regard to smoking, if you smoke, it'll impair your power of concentration somewhat for about 20 minutes after you've had a well-inhaled cigarette. So I would advise against that. But it won't in fact give you a tremor. If you drink, you would have to drink to excess to get the kind of tremor that would seriously impair your microsurgical performance. Of course, if you come into work well clouded with a hangover, that'll impair your concentration, but that's not what we're talking about. I'm talking about tremor right now. Coffee, this is an important point. If you are a habitual coffee drinker, the important thing is to know what your normal level of coffee consumption is and stick to that, cup for cup and day by day. That way you'll keep your tremor at a minimum. If you exceed your normal intake of coffee, your tremor will get worse. If you drink very much less than your normal level of coffee intake, your tremor will get much worse. So if you're an addict, as I am, stick to your normal level of intake. With regard to those other forms of enjoyment too that we're supposed to abstain from if we're to be perfect microsurgeons, I can tell you that in fact that isn't important either, but maybe thinking about it is. And I don't know just what you can do about that, but you don't need to lead a monastic existence in order to be an effective microsurgeon. Having said that, and disposed of perhaps some old wives' tales on the matter of tremor, there are two things which will make your tremor worse, your basal tremor. The first is strenuous manual exertion, and the second is getting annoyed. Now, if you do any heavy work which involves prolonged, vigorous use of your forearm muscles, like heavy lifting, like playing tennis, like sailboat riding, like working in the yard, or like using hand tools, that will increase the level of resting muscle tone in your forearm for even as much as 24 hours after you do it. So think of that. You obviously can't redesign your life and all your recreational pursuits around that fact, but you can sometimes avoid cutting down a particularly large tree or engaging in a log splitting contest the day before an important microsurgical procedure, because it does have a very marked effect, believe me. With regard to irritation, you all know, I'm sure, because we all have our threshold of irritation, that once that threshold is passed, you'll get a tremor. Now, avoiding that takes us back to what I was already talking about in terms of having everything prepared and nicely set up so that you get no surprises and no irritations while you're carrying out your procedure. If you do get really annoyed about something or somebody, for goodness sake stop, deal effectively with that source of annoyance, and give yourself 10 minutes to quieten down before you resume, because there's nothing more disastrous than continuing to work when something is right in the front of your mind, annoying you. Having said that, I'd like to show you 3 hand positions, one of them good and 2 of them bad, And I'd like to show them to you under the microscope. We'll turn this monitor on here so that you can watch what I'm watching down the microscope. And having shown you the difference under the microscope, I'd like to then look at them from a distance and see what the differences really are. I'm going to just present you with the sight of my right hand instrument and my left hand instrument trying to stay still. Right now I'm using a very bad hand position and I'm trying to keep my hands still. I'm really trying, believe me. And the harder I try, the worse that random movement gets. This is the very stillest that I can keep in this bad hand position. If I try to pass a suture with this much random movement going on, it is entirely a matter of chance whether I pass it accurately or disastrously. And while I'm passing the needle, the amount of unwanted pain and trauma that's inflicted on the tissue is about 100 times that which is actually necessary for the mere passing of a needle. Added to that is the fact that the psychological trauma on the surgeon of trying to do work in this state of total uncontrol is very severe indeed. It just isn't worth trying to do microsurgery with this much unwanted movement going on. Well, that's a very bad hand position, and we'll look at it from another angle in just a minute. Now let's look at another bad hand position, not quite so bad, but bad in a different way. Here I've changed to where the big unwanted movements have stopped, but instead I've exchanged it for another evil, which is a very rapid, high-frequency tremor. Once again, I'm trying very hard to keep my hands quite still. Once again, the harder I try, the worse it seems to get. I can pass the needle now with slightly greater accuracy than before, but again, it's a worrying business, and again, just watch that tissue. I know it's only a piece of rubber, but it might be a living vessel. Just consider the amount of additional trauma that's being added to the necessary minimum in the passage of that shaky needle. It's almost like taking a pneumatic jackhammer to the tissues. So that again is a real bad position, and we'll look at it in a moment. Now, here I'm using a good hand position, and there's another difference too. I'm not even trying to keep my hands still. My hands are staying still simply because of the position that they're in. And I can maintain this position effortlessly just for as long as I please. I can make a little circling motion there deliberately, which is only a few thousandths of an inch in diameter. And it's the only movement that's going on. I can pass this needle, which I'll just do in slow motion here, in the absolute assurance that the only movement that'll happen is the movement which needs to happen and which I intend to happen. There's no trauma there except the absolute minimum which has to be. And there's the peace of mind of knowing that in this hand position, nothing unwanted is going to happen. Now, let's take a look at that hand and that position from a distance here, and perhaps if you could come to where we can see my hand closer, I'll really be able to show you this in detail. While I'm showing you this, you might like to just take one of these instruments each and put it in your right hand so that you can, to some extent, copy what I'm doing. There we go. In the first position, the really bad position that I showed you, I had my hand completely up in the air, unsupported like this. In that position, any movement that I made with my upper arm, with my neck and shoulders, with the lower part of my body, could all be transmitted straight through this fine system of levers right down to my fingertips. There's no effective support whatever. In the second hand position, I made this one small change. I put my wrist down on the table so that my forearm was at rest, and that got rid of the big movements which arise mainly from the upper part of the body, but it didn't get rid of that little fine tremor which began to look, in fact, even worse than it had been before. Now, that fine tremor arises from the fact that muscles are working, these muscles right here, and they're working to keep the hand up off the table. For as long as those muscles go on working, that's the extensor carpi radialis, that very fine tremor at the tip of the needle will continue. So I don't need to tell you what I did to achieve that very fine control that you saw in the third and good hand position. I'm sure you figured it out already. I put the tip of my hand down, and that is enormously important. The tip of your hand must be resting on something solid, and when I say the tip of your hand, in the case of most people, hand, this means the tip of the middle finger. This must be resting either right on the table, like so, or stacked up on one of its neighbors, or even two of its neighbors, but there must be something solid directly below that middle finger in order for you to have fine control. Now, you may say, that's all very well in the workshop and on the workbench. What about the operating situation where you don't have a good solid support? Well, we'll come to that later, and I'll show you what a good operating hand position is. It's a modification of this, which we'll come to in due course. Right now, let's concentrate on this basic workbench position and consider some further details of it. If you'll just take that instrument in your hand and look at it at the same time that you're looking at this, I can tell you some useful details about a good instrument holding position. Quite apart from the fact that you've got it resting firmly on the table, there are some other important things. Firstly, these two fingers, the two ulnar fingers, they don't have very much to do with the instrument holding. The only thing you need to think about with them is just to curl them up a little and tuck them inside the palm of your hand. Don't have them out like that. That isn't a useful hand position. If you just curl them up like this, they'll stay out of the way. Now let's think about those three important fingers, the thumb, the index, and the middle. As you'll notice, they're neither hyperextended, which is uncomfortable, nor are they hyperflexed, which is also uncomfortable. You may have heard that you ought to hold a micro instrument as though you were holding a pen. Well, a lot of people hold a pen like that. Don't do that. Just have them comfortably semi-flexed, like so. You need about an inch of the instrument projecting beyond the tip of your fingers. If you have too much, then you can't rest the tip of your fingers on the table. If you have too little, then you can't get to work at all. So about an inch is correct. And for most people with normal-sized hands, these 13-centimeter instruments are a much better length than the rather tiny instruments which used to be standard in microsurgery. They're better because you can rest them against the MP joint of your index, which is a good place to rest something. If you have something which can't be rested against that joint, you just don't have so much control over it. Now, another important point which you can't see so well from this angle, but which we'll see better from straight in front of the hand, is how these three fingers come together. These three fingers, if you look at them closely, the three essential fingers of the famous chuck grip, are touching one another. And that's a very important point. They're not set apart from one another. They're gently touched together. And the instrument just looks out from a little hole in the end there. The fingers are touching all the time. Now that's important because if you ignore this simple point and let your thumb float free here, free of the other fingers, you'll find that this happens. the side of the instrument which is controlled by the thumb will constantly be subject to this little tremor. I'm exaggerating it deliberately here, of course. It's a little tremor which comes from the thumb itself. That thumb tremor can be completely damped out if you simply touch the thumb against its neighbors. You'll then find that you can open and close the instrument with very perfect control and with much greater peace of mind than if you have the thumb standing out in the breeze like so. We've talked about psychology, about comfort, and about hand position. And now I'm going to talk about adjusting the microscope, and I'm going to talk about instruments. This is a rather ornate teaching microscope. Disregard some of its complexity, if you will. There are some very simple things that you must know about and which you must attend to every time you sit down to work with a microscope. Nobody else is going to take care of these simple things for you. You, the surgeon, have it as a duty to take a look at that scope when you come in the room, check it over, and make sure that it's going to work for you today. Do this again as part of your surgical technique, as part of the job that you do. You check over electrical, mechanical, and optical factors. All very simple. Electrically, you turn on the light and you make sure it's good and bright. If it's partly bright and partly dark, that often means your bulb is about to fail. You might as well know about that ahead of time and put in a new bulb rather than have it fail right in the middle of the procedure. You turn on whatever switch is needed to turn on the remote control functions of your microscope, and you check out the foot pedal if your microscope has one, and see that when you want the microscope to go up or down, it does so. When you want the microscope to change magnifications, it does so. If anything's wrong, or even slightly wrong, with those electrical systems, you better get it checked out and corrected before you start. Mechanically, it's important that you be able to bring the microscope to where you will be working with the minimum of upheaval and fuss. Now, in the lab, this isn't a factor. Your microscope is set up right by the table. But in the OR, it can require a surprising amount of upheaval to bring the microscope to the patient unless you think about that ahead of time. Think how you're going to bring the microscope from where it is now to where it's got to be. Think just where it's going to stand next to the table, and make sure that the microscope you're going to use has a long enough arm from here to here that you can readily bring it into action without discomfort, without uncomfortable proximity between you, the table, and the microscope stand. Still talking about mechanical factors, make sure that these movements of the suspension arm of the microscope are just semi-tight, so that when you want to move the microscope around, you can move it around, and when you want it to stay still, it'll stay still without drifting. It's a mistake to have these loose, but it's a real mistake to have them done up too tightly. If they're too tight, you have a fight on your hands every time you want to adjust the scope. Mechanical factors continued on out to the business end of the microscope bring us to these two tilting adjustments. The tilting adjustment, both up and down and sideways, is frequently used to give us a combination of a good access of view and also good comfort of body position. And it's the one adjustment which you sometimes have to wait till you're in the middle of the operation before you finally set it. Once it's set, that does need to be screwed up rather tightly, otherwise your microscope's liable to capsize. Now, so much for mechanical factors. Let's finally get to some quite important optical factors, very simple ones. Your lenses need to be clean, and the top-end adjustments need to be correctly made. Once you've attended to all those things, your microscope's ready to use. Now, this objective lens gets dirty very readily. Blood will sometimes get onto it, but more frequently Ringer's solution or saline irrigation solution will get onto it, and it'll dry off and form a little frosting which will really impair your view. So you check that out. Don't assume that anyone else has checked it out before you, because they won't have. You can clean that with a plain piece of cloth, not too fluffy, and at the same time clean your eyepieces. Make sure no dust has got in there. That brings us to the adjustment of the top end of the microscope. And I think, just so that I can show this to you readily, I'll take the top off the microscope, although it certainly isn't necessary to dismantle the microscope in order to make these adjustments. The top end of the microscope has two adjustments which have to be made personally for you. The first is the interpupillary distance, and the second is the individual eyepiece focusing adjustment. The interpupillary distance has to be set correctly to the nearest millimeter if you're going to be able to see in 3 dimensions. And if you do not have it correctly set, and if you don't have a stereoscopic view, you'll find the work is almost impossible. Now, if you haven't looked down one of these before, let me give you a word of advice. Don't try and set the interpupillary distance with your eyes right up against the microscope. Set that interpupillary distance after just backing off by an inch. Just back off by this much, and then either push them together, pull them apart, keep on adjusting them till you see equally with both eyes. If you have your eyes too close up here, you'll see 2 great big circles, and it won't be too easy for you to tell when you've just got them coinciding exactly. But if you back off by 1 inch, instead of looking at 2 great big circles down those eyepieces, you'll be looking at 2 little bitty spots of light, and it's very easy to bring them just exactly together. Then you've got your interpupillary distance correct. A lot of microscopes have a little millimeter scale set right here. If you know what your interpupillary distance is, that's fine. Just set it right there. Last but not least, and most confusing to many, let's cover this adjustment here, the individual eyepiece focusing adjustment. This must be set correctly for you, for your eyesight, before you sit down to work. This isn't the adjustment by which the whole microscope is brought into focus. This is the adjustment by which you bring yourself into agreement with the microscope. If you have normal eyesight, all you need to know is that this adjustment should be set right on 0, and it'll be correct for you. 0 on one eyepiece, 0 on the other eyepiece, and you're all set to go. If you're nearsighted, then you must set it to -1 or 2 or 3, depending on how many diopters of eyepiece correction you have. If you know your prescription is -1.5 diopters, you set it right like that, to -1.5. If you're farsighted, you set it to +1, +2, +3, and so forth. Now, why is this important? It's important because if you don't have it correctly set, you'll find that the microscope will go out of focus every time you change magnification. When you go from high to low, or from low to high, your view will become blurred, and you'll have all the trouble of refocusing the microscope before you can proceed. When that happens 50 times in the course of a procedure, it gets mighty tiring. If you have this correctly set, you can remain in focus regardless of any magnification change, always assuming that your view was in focus in the first place, which we'll come to in a minute. One small thing, when you've adjusted the eyepieces, make sure that you push them firmly down into their seating so that they're sitting at their optically correct point. If you have it 1/4 of an inch up like that, that's just like having a 10 diopter malcorrection on it. Make sure they're down. Another small point, if you have very strong eyeglass correction, more than 3 diopters, you're better off keeping your glasses on, taking the rubber protectors off the eyepieces, like so, and setting these adjustments to 0. If you're extremely nearsighted, do that. Otherwise, you have the problem that you can't even see the equipment that's on the table in front of you. Now, I just want to say something about whether your view is in focus or not. I said when you correctly adjusted this, your view will stay in focus, assuming it was in focus in the first place. If you're at low magnification, you have considerable depth of focus, about an inch altogether, and therefore considerable margin for error in just where you have your microscope poised in space. You may have it as much as half an inch too high or half an inch too low, and you will still get the impression at low magnification that your view is in focus. Then when you go to high magnification, your mistake is revealed, because at high magnification your depth of focus is negligible. It's just a fraction of an inch. The moral of that is obvious. Go first to very high magnification. Adjust the overall height of your microscope with the focusing adjustment until you've got a sharp view. Then you can say, I'm in focus. Change to whatever magnification will then enable you to do the job in hand. The only other thing that's ever going to put your view out of focus is, of course, if the object that you're working on moves. And that you try to minimize as far as you possibly can. So finally, let's talk about instruments. When it comes right down to it, the work you do is done by your instruments. And the better your instruments are, the better your work is going to be. Unfortunately, we still have with us that bygone belief, which belongs to the Puritan work ethic, that there is something intrinsically noble about trying to do a good job with bad instruments. This belief absolutely does not apply to microsurgery, whether in the OR or in the lab. If you're not using the best instruments that are available, you're not doing the job right, and you should regard it as a fundamental fault of technique to even contemplate using bad instruments to do a job where the margin for error is so tiny. And certainly in the lab, you should use good, new, well cared for instruments. Don't use instruments that have been thrown out of the OR. Use instruments that are even better than the instruments in the OR. If somebody's in the OR and says, oh, this is bent, send it to the lab, the only good teaching value that can be made of that instrument is to put it in the hands of an expert and get him to demonstrate how good work can be done with it. But apart from that, the only thing to do with a bent instrument is to dismember it limb from limb and make sure that it never gets back into the hands of a surgeon, particularly not in the lab. I think the concept that second-rate equipment is good enough for the lab is an absolute insult both to the lab in general and to our surgical trainees. Now here in this lab, if you even think there's something even slightly wrong with one of your instruments, if you even think there might be, we expect you to comment on it. You may comment rudely on it. We hope you will. I would hate for any of you to waste any of your time working with an instrument that's even a little bit bent or a little bit out of whack, because we do aim to have the best possible instruments here for you to use. Let's just briefly look at the instruments that are here. These are what I would regard as sufficient for basic microsurgical practice. We have a pair of angulated jeweler's forceps, which are very useful as a light needle holder. We have a straight jeweler's forceps. We have a vessel dilator, which is a special purpose instrument that we'll come to later in this series of tapes. We have two pairs of scissors, a curved round-pointed dissecting scissors and a straight sharp-pointed adventitious scissors. We have a little clamp applicator forceps which goes with this double clamp, of which we'll see plenty more at a later stage. And for our initial access and exposure, we have a scalpel, a pair of toothed ophthalmic forceps, and a pair of ring-handled scissors. Lastly, but not least, a little piece of blue plastic background material completes our instrument set. These instruments live on a foam rubber pad, and unless they're in your hand, they should be back on that pad. When it comes time to clean them, they should be picked up one at a time and put in the cleaning bath. We'll talk about instrument cleaning in just a little while. I'd like to turn to the other camera. I'd like to say a few general words about instruments, not in the lab, but in general. If you're going to do any amount of microsurgical work, it becomes essential for you to have your own instrument set. It needn't be a very grand instrument set, they needn't be very expensive, but they must be yours, and they must be only yours, and they must be well cared for. And here are a few general thoughts on that. Before you get any instruments, you need to get a case to put them in. A case such as this one, which has a lid, it's ventilated, and which has inside it a rack with a space for each instrument. The instruments can stay safely in that rack, and in that rack they do indeed live. They live in that rack when they're in storage, they live in that rack when they're being autoclaved, they stay in that rack when they're brought to the operation and they're put on a Mayo stand beside you, and they only come out of that rack when you're good and ready to use them. As soon as you've finished using them, they go back in there, whether clean or dirty, and they stay in it till it's time to clean them. Now, if you make that an absolute rule, you'll hold on to your micro instruments and keep them in good shape for a remarkably long time, because they don't get damaged while they're in your hand. They get damaged when they're on the way to the operation and when they're on their way from the operation. And especially they get damaged at cleaning time. Micro instruments should never be mixed up with any other instruments at any time, especially not at cleaning time. If you hear somebody pick up a handful of micro instruments and throw them in a sink along with all the other hardware, you can kiss those instruments goodbye right there. Because you see, to mortally damage a pair of jeweler's forceps, it's only necessary to drop them on a hard surface from the height of about an inch. If I did that on a hard surface with the tip of this jeweler's forceps, I would deform the tip by at least 1/1000th of an inch, which is a large deformity. It is a large deformity because these forceps have to handle 10-0 nylon, and 10-0 nylon is 1/1000th of an inch in diameter. You bang up your instruments by 1/1000th of an inch, you may as well throw them away. Now, this begins to sound awfully threatening. How in the world can you protect your instruments from such even minor abuse? Firstly, as I say, by keeping them in a tray. Secondly, by making it a rule to everyone who handles them that their tips will never touch another hard metal object. Never, never any other hard metal object. This includes the tips of other instruments. So that dictates to you some simple rules, such as the fact that you will always pick them up one at a time and put them where they've got to be. You won't ever pick them up in a handful and throw them anywhere. When it comes time to clean the instruments, take them one at a time and put them in a bath of hemolytic enzyme detergent and leave them there for 10 minutes for all the blood to soften. Then take them out and rinse them in plain water and dry them either with a cloth or in the air, and then put them back in their rack. And when they're good and dry, you can put the top back on that box and put them away for storage. Don't put them away wet, because high quality instrument steel, although it's stainless, it's only fairly stainless. There are degrees of stainlessness, and it will rust if you put them in a closed box still moist. Another point, when it's time to autoclave the instruments, autoclave them and then use them. Don't do what's done in some ORs, autoclave them days ahead of time and then leave them wrapped in a towel on a shelf, because likely there'll be some dampness trapped in there, either in the case or in the towel, and that'll make them rusty. Another point of detail which can become a major hazard is the matter of magnetization. All high-quality instrument steel is magnetizable. There's no getting away from it. Magnetism arises partly from being in contact with other magnetic objects, and partly from trauma of a direct nature. If you put your instruments down on a piece of electrical equipment that has a transformer or a motor in it, there's a danger they'll get magnetized. Sutures likewise. If you put your instrument or your sutures down on a metal shelf which has previously had something magnetic on it, they're liable to get magnetized. And the first thing you'll know about it is when you sit down and try to do a job of work and you find the needle is either running away from your instrument or vigorously adhering to it. The cure for this, there's no absolute means of preventing it from happening in a normal OR, but the cure for it is to have a simple demagnetizing coil such as this one, place the instrument inside the coil, turn on the current, and slowly but slowly withdraw the instrument until it's 2 feet away, and then turn off the current. It's a very easy thing to do. It's a very easy thing to buy, and it's really a very small problem once you have the means of cure at hand. Well, that completes what I have to say about the basic preconditions of microsurgical work. What I suggest you do at this point is to sit down with your microscope, get comfortable in your place of work, and without any further instruction, take a piece of practice rubber and do a little suturing with the positive intention of getting a little bit frustrated and experiencing a little bit of preliminary difficulty. Not in any masochistic way, but so that when you come to look at the tape on suturing technique, some of those many, many points of detail that are on that tape will have some meaning to you. So that's what I suggest we do at this point.
Welcome to the Microsurgery Laboratory in the Department of Orthopedic Surgery at Columbia University. I'm Dr. Robert Strauch. This is the second in a series of instructional videotapes on microsurgical technique. In this video, you will learn how to set up the microscope correctly. We will show you proper hand positioning and posture for successful microsurgical technique. And we will review the instruments that we use. I hope you find this videotape useful in your future microsurgical pursuits. Before we begin, it's important to go over the basic working parts of the microscope that you will be using. Every microscope may be different, but there are features common to all microscopes that it is important to know about. This is your basic operating microscope. This model we use in our laboratory, and it is equipped with a camera as well as an external video source for training purposes. But in the operating room, frequently the camera will not be connected. The basic parts of the operating microscope, common to all scopes, are this part, the part that you look through. This has the eyepieces and the objective as well as a cable for the light source. There's a body that controls the intensity of the light source and the up and down motion of the scope, and is a solid piece so that the scope doesn't move and jiggle while you're operating. And there's a foot pedal that's connected to the base usually that controls both the zoom and the focus, and frequently we'll have a little joystick that you can move with your foot to control the XY orientation of the scope to move it in the correct position for fine positioning purposes. Let's look at the biggest part of the microscope first, the body here. You'll notice that there are some cords coming out of the body. One of them goes to the electrical outlet, and it's essential that this be plugged in or the microscope will not work properly. There's usually another part that goes to the foot pedal, and there may be other cords that go to the other pieces of the microscope depending on your own particular scope. Now, assuming the microscope is correctly plugged in, there's usually a separate power button to press, and then there are other controls to turn the light on for the microscope, and usually we'll turn these up to the maximum. There may be 2, 3, or even more knobs for this purpose. One thing that's crucial to know about is where the light source is for your microscope. This may not be important for the training situation, but in the operating room, it is a disaster to blow a light bulb and not have a replacement or not know how to put the replacement in, because the operating room nurses cannot be relied upon to fix the operating room microscope. So let's look at how to do this. Every microscope is a little bit different, but there's usually an area where the light source will be contained. This particular scope has a little drawer, or it may be on top of the scope or on the side. Now, one of the things you might want to do if the bulb blows out is to detach the light source cord and plug it in to the adjacent bulb, which should be working. If the adjacent bulb is blown out, then you're going to need to change the bulb. This is the module. What we do is we remove the bulb, unplug this thing, change the bulb, put it back in place, put this thing back together again, like this, and then just slide it back in the drawer. And then close it up. Now let's go over the components of the microscope head, which is the part that you will actually be looking through during the operating technique. Usually this swings around 360 degrees, and let's take a look at the different components of it. On the top here, in this particular microscope, there's a little button, and many microscopes will have this button, and this is to centralize the XY position of the microscope. When you press this, and this happens to be facing to you, then this will synchronize with the foot pedal, and then when you move the foot pedal, if it's facing you in the correct position, the microscope will shift in fine movements accordingly. Let's look at the objective lens. If we go down here, we see this one happens to say f200. Now what that means is that the focal length of this lens is 200 millimeters. Let's see if we can unscrew the lens here. We can show that this lens will focus at 200 millimeters. Now there are lenses with an f400 and various numbers, and what that means is that if you have an f400, your scope is going to be much further away, twice as far in fact, from the surface. This may be good if you're doing an ENT case, but if you're doing microsurgery on a limb, you want it to be closer so that your arms are not very far away from your working surface. So for this particular microscope and training situation, we're using a 200 millimeter focal length, and these are easily changed by just screwing them back into the microscope, like that. Now the eyepieces are also adjustable frequently. First thing you need to learn is your interpupillary distance. Everybody's is different. Some people have close set eyes and some people have wide set eyes. The way to check that is to put your eyes and look through the microscope so that you see one circle, not two. If you're seeing two, that means that your interpupillary distance is off. And you can check it because there's usually a little number here that shows you what your interpupillary distance is. Once you know what your interpupillary distance is, it's a good idea to write it down, because then when you go to a different microscope, you can probably set it for the same position as a trial. Now the eyepieces are usually also detachable, and these, you will notice, have a little ring to rotate. Now this is so that you can focus and take into account any differences in the refractive properties of your two eyes. If you happen to be 20/20 in each eye, then you would want to set this for a setting of 0. Sometimes there is no 0, there's just a little line with plus and minus, and you can rotate the white line to that after you've screwed it in all the way to make sure it's set at the maximum inset length, and then you put it in the neutral position. What you would want to do then is to look through each eye, close one eye at a time, and focus so that it's in the correct focusing position for each eye. Now let's look at the foot pedal controls for the operating microscope. While different models will have different controls, usually there's one pedal to adjust the fine focus and one pedal to adjust the zoom, that is zoom in and zoom out. Also, scopes will frequently have an XY attachment. This is a joystick that will control the motion of the microscope in millimeters one way or the other, it's important that this be synchronized with the control on the microscope. When you press the button on the top, this will centralize it, and from then on in, movement of this joystick will cause the scope to move in fine increments. If this is turned the opposite way, when you move the joystick, the microscope will move in exactly the opposite direction from the direction you intended to go. So it's important that this be facing you like this on the floor, and then when you move the joystick, the microscope will move in the appropriate direction. Additionally, our microscope has a foot control with pedals that will control the overall height of the scope in this manner, up or down, for gross focusing purposes, so that you can get within the focal length of our lens, which happens to be 200 millimeters. Other microscopes will have a manual control up and down, that you just grab the entire head and move it up and down in order to control the gross focal length. Now the focus control moves the scope up and down a little bit. So when we press it, this goes down and this goes up. Now when you begin to operate or to train, you want the scope to be in the middle of the focusing distance so that you have equal ability to focus up as well as to focus down. In order to do that, there's usually a little dot that will help you in order to get the central portion of that focal length, focusing distance, and you want these two to line up with one another. Usually most scopes will have some kind of a similar dot on the head so that you can focus in this way. Now you're ready to begin doing some actual work. Let's review some basic principles first. Your microscope is correctly positioned with respect to the eyepieces for the interpupillary distance and the individual focusing of each eye. Your assistant should also have positioned his or her eyepieces in the proper manner. The XY diagram is facing you, the person that has the control of the foot pedal, which should be on the floor directly in front of you. There's nothing more annoying in the middle of an operation than to have the foot pedal move all around, and it's important that you know exactly where it is. You can either use a shoe or take your shoe off, and that way you'll have a little better control over the foot pedal. Now, to actually get down to looking through the microscope, first you want to make sure that you zoom in all the way to the highest magnification possible. In this way, when you are focused at the highest magnification, you can zoom out and everything should be in focus. Next, we look through the scope and we either use the up and down control that's on the foot pedal, or if you do not have such a control on your foot pedal, you manually move the scope up and down so that while you are zoomed in at the highest magnification, the field comes into focus. Now, this is focused as best as possible using the gross motor controls. However, you then want to take the foot pedal and use the fine focus in order to further focus this correctly. You'd like to make sure also that you haven't forgotten to put the up and down diagram in the center so that you have the maximum focusing distance possible. Now, once this is set, you are at the proper position with respect to the level of the scope from your working field. You now have to position yourself in such a proper manner. In order to do this, it's imperative to have some kind of an adjustable chair that will move up and down so that you can position the height of your body at the correct level of the scope. In order to do this, you don't want to be too hunched over or too high up in the air. You'd like just to be at the correct level and to be comfortable looking through the scope. You'd like your hands to be comfortably resting on the table. We usually use some padding so that your forearm is not resting on the sharp edge of the table, and your elbows should be comfortably bent. Basically, you want to make yourself as comfortable as possible because you may be doing a long microsurgical procedure, during which time you can become more fatigued if you are not comfortably positioned, to say nothing of developing neck and back strain. An additional point about microsurgical ergonomics that our laboratory director, Yelena Akalina, has come up with is the use of one of these cold hot packs placed in a soft bag, or you can use bags of IV solution or just folded towels to rest your forearms and elbows comfortably, as well as your wrists, so that you are totally comfortably positioned for microsurgical technique. These are the finely crafted instruments that make all this work possible, in addition, of course, to a trained microsurgical professional. Now, you'll notice that these instruments are very small, much smaller than the usual instruments in the operating room. They're very fine. The tips of this jeweler's forceps you can hardly even probably see. You can imagine what would happen if you accidentally dropped these on the floor with the tips facing down. These would be irreparably damaged. So it's very important to take extreme care when handling these instruments that you don't knock the instrument tips into one another, or drop them on the floor, or carelessly throw them at the scrub nurse, hoping that they will catch them. Because these are expensive instruments, and you like to go through as few as possible. Now, let's review the various instruments that we have to work with for training purposes. These are the instruments we will be using. First, a standard scalpel blade with number 15 blade, and a tissue forceps for dissecting the superficial layers of the laboratory rat model. Also a scissors for dissecting purposes. Next, a clamp applicator for applying the fine vessel micro clamps. Next, a curved needle holder that is used for grasping the needle for suturing purposes. Next to that, we have a sturdy jeweler's forceps, and these are all microsurgery instruments used for dissecting the vessels. Next is a curved jeweler's forceps that can be used as well as for a needle holder. Next is a fine jeweler's forceps, a number 5 for fine picking up of material. This is a vessel dilator with very thin points that are blunt on the tips. This is a dissecting scissors used for tissue dissection. And finally, a pair of adventitious scissors using for cleaning off the adventitia from vessels. Next, we have blue background material. We have single vessel clamps and a double vessel clamp. In order not to lose these clamps, it's helpful to have a clamp tray in order to maintain all of our clamps. Of course, no microsurgery set would be complete without 8/0, 9/0, and 10/0 nylon, the 10/0 being the finest of the nylon sutures. Thank you for watching this videotape, and I hope you found it useful for your microsurgical training. On behalf of the microsurgical staff here at Columbia University, the Department of Orthopedic Surgery, I would like to wish you all the best success in your future microsurgical career.
I'd like to welcome you all to the Orthopedic Research and Training Laboratory in Microsurgery. I'm Dr. Harold Dick, Professor of Orthopedic Surgery at Columbia University. We initiated this laboratory some 19 years ago to its present state of the art. The discipline of microsurgery dates back to the post-World War II years. At that time, the development of the fine needles and suture material made it possible for the very fine suture anastomosis that had to take place. Jacobson was the first to advocate the use of a microscope for small blood vessel anastomoses. The leaders that subsequently followed were O'Brien from Australia, Ackland from Louisville, Kentucky, and Sun Lee from San Diego, California. The clinical uses in everyday practice that have developed up until today's date have been varied and very, very dramatic. They include OBGYN, urology, ear, nose, and throat, neurosurgery, plastic surgery, orthopedic surgery, ophthalmology. All have incorporated the microsurgical techniques to address their very complex problems and have made technological breakthroughs that have been very dramatic and far-reaching in their own fields. The principles of training in the laboratory itself include having obviously a sound and a clear mind in a sound and a well body. And this includes an open mind because learning microsurgery is a hard task, but the important point is to be prepared physically, mentally, and emotionally. It would be marvelous if you had the opportunity to take a nap before every case, but certainly mental preparation is most important, and I mean having your mind open and clear to make a fresh start in learning the new surgical techniques. Don't be afraid of making mistakes. We would like to learn the right way and fix any mistakes as we go along. Don't be afraid to ask questions. Respect the expertise and the readiness of the instructor to help you when you feel you need it. Sometimes little tips make a big difference in the course of a procedure, and they certainly mean a lot in the course of learning this technique. Many people taking this course already have certain surgical techniques in their hands, but we would like to advise you that microsurgery techniques might be very different from anything or everything you've learned before. Sometimes macrosurgical knowledge can be dangerous when brought to the microfield. Certainly the picture of doing finger or hand ties in the middle of a microsurgical case is startling and very inappropriate. Have your self-control and patience ready, because you're going to need truckloads of it. Do not become frustrated with the learning process. Even though you may be a skilled surgeon, it may take some time to readjust to a microscopic environment. The size of the tissues, the fineness of the instruments and the suture material, the fragility of the vessels will contribute to this difficulty. Most of all, it's important to be gentle. The key to success is gentleness. You always have to keep in mind that you are dealing with very fragile vascular and neural tissues, and rough handling would never lead to good results. Your friendly neurosurgeon can tell you this from past experience and present experience. There is a difference between being strong and being rough. Pretend you are holding the wings of a butterfly. This is how we will be handling the tissue you are going to work with today. One of the real principles is comfort. Comfort is a very important issue in performing microsurgery and should be taken very seriously. Make yourself as comfortable as possible and take your time to do it. Being comfortable plays an important role in the successful outcome of surgery. It reduces fatigue and stress and ultimately your final outcome. Be very careful with your body's posture. You might have to last 2 to 3 hours in the position looking through the microscope, and that requires the right surgical stool and the correct adjustment of its height. All this should be done prior to starting the case, prior to actually bringing the nurse and the sterile field into the room. Take your time adjusting your sitting position and try it out several times. It will save you operating time in the end. Take regular 5-minute breaks every 1 to 1.5 hours of work to stretch out, relax, and get rid of the cramps. A number of factors can cause an inherent hand tremor. Factors such as sleep deprivation, physical exertion of the muscles controlling hand and finger movements, heavy weightlifting, nicotine and coffee consumption, and excessive stress and anxiety. For heavy coffee drinkers of 3 or 4 cups a day feel that it's worthwhile when they have a scheduled case to omit the coffee. Well, this is well known to not omit the tremor. Therefore, get a good night's sleep. Do not overexert your shoulders, arms, or hands. Don't lift heavy weights or work out to exertion the night before coming to Microlab, and in particular in the morning before. Don't overconsume your caffeine, nicotine, or alcohol just before and during the course. And avoid excessive stress and anxiety as much as possible. The purpose of you taking this course is not only to have new microvascular techniques, but also to learn to increase your appreciation of tiny tissues, to develop eye, hand, and foot, as well as brain coordination, to work with the surgical microscope, one of the great technical breakthroughs of the past century, to concentrate on a very small area of surgery in a very small field, to handle micro instruments and very fine sutures that are often the size of a hair. All these skills will always be very useful to your future surgical practice. Whether or not you become a microsurgeon every day is not so important. But with this in mind, let's get started with our training. This was the first tape in a series of microsurgery training course videotapes. The following tapes will discuss suturing techniques and other aspects of the actual procedures. They will be presented by members of the microsurgery faculty of the Department of Orthopedic Surgery of the Columbia Presbyterian Medical Center at the New York Presbyterian Hospital. This tape has been made possible by a very generous educational grant donated by the Sharp Point Surgical Specialties Corporation. They have produced the suture materials that the laboratory has been using for more than 10 years.
Welcome back to the Microsurgery Laboratory. In this videotape, we will review the basic techniques for microsuturing using a practice model before we move on to the rat. Now let me show you the practice model that we'll be using. This is a piece of latex rubber that is stretched over a plexiglass ring with a cut in it. And the cut is what will be sutured. The ring can be rotated so that you can practice sewing in different directions. Now before we actually get started sewing on the practice model, let's review some of the basic hand motions and techniques for microsuturing, because this is different from the suturing technique that you're used to in the operating room. Now let's look at the way most of us are used to suturing in the operating room. For many of us this is second nature, and we really don't think about what we're doing because it's become a matter of routine. But it's important to review some of these steps to point out the differences between normal instrument tying and microsurgery instrument tying. Okay, first, what we normally use in the operating room for macrosurgery is a standard ratcheting needle holder in the right hand, and in the left hand we will have a forceps of varying natures. This is a large needle, a number 2 needle for demonstration purposes. Normally the needle is grasped about 2/3 of the way from the tip for maximum stability. And the needle is passed through the tissue by everting the skin edge 90 degrees. Here we're going to use a towel to demonstrate, everting the opposite skin edge, passing the needle by rotating the hand, and then tying the knot. Now in the operating room, people usually either pick up the suture by hand and make a loop, or more elegantly use the forceps to pick up the suture and, crossing the hands, make a flat square throw followed by another flat square throw followed by yet another and maybe even a fourth. Notice that I have not tightened these down just to demonstrate that they are all going to be square knots. Now, it's sometimes hard to get a perspective on what's happening when the camera is facing me, so let's look over my shoulder so we don't have a mirror image problem when we try to demonstrate the differences between normal suturing and microsuturing. Let's look at some of these steps in a little more detail from over my right shoulder. It's not much of a problem to pass the needle. Most of us are very familiar with that. And the tying part is almost second nature, as we indicated, but let's just go over the mechanics because this is important when tying loops in microsurgery. Now normally we approach the suture with the left hand pronated in order to make a loop. This creates a nice loop so that it will fold easily around the needle holder and lay down flat. Now notice the left hand was pronated or palmed down to make that loop. If the hand is supinated and grabs the suture with in this way, the knot can be made, but it's not, when you're doing microsurgery, as easy to make it as it is when you're doing it with the hand beginning in a pronated fashion. It's just a more natural action to begin with the hand pronated in this way. Well, what's the difference between normal suturing and microsuturing? For one, we do not use the traditional needle holder with a ratchet type mechanism in the right hand when we do microsuturing. We typically use either a curved jeweler's forceps, which is used in many laboratories across the country to teach microsuturing techniques, or more commonly in the operating room, we will use the curved needle holder to drive the needle, since it gives a more secure purchase on the needle when you're driving it through atherosclerotic vessels. The second main difference is that we don't hold the instruments similar to the needle holder, but we hold both instruments in the left hand, which is already being held with a pencil type grip. In the right hand now, we use a pencil type grip for the instrument. Now, to the outside observer, when doing microsurgery, it doesn't appear as though the microsurgeon is doing very much, and that's because the hands are not moving. The motion comes through the fingertips, and there's very minimal translation that occurs in order to accomplish the microsuturing. Okay. Now let's review some of the details of microsuturing seen from a macro perspective. I'm going to simulate using jeweler's forceps with two large forceps so I don't destroy our fine microsurgery instruments. Normally, when we're putting a needle in the needle holder in the operating room for normal surgery, we will pick up the needle or hold it with another instrument. And this really is almost impossible to do in microsurgery because, number one, you can't pick up the needle, and it's hard to grab it because it sometimes flies away. So first of all, one easy point in terms of picking the needle up is to grab the suture attached to the needle and spin the needle up in the air and then grab it about 2/3 of the way down. Okay, now passing the needle through in microsurgery does not involve picking up the tissue end and then squeezing it, because this will oftentimes crush the end of the tissue. We simply insert the forceps underneath and exert some pressure so that we can pass the needle in an atraumatic fashion. Now let's just review some of the details of making the loop. First of all, when making the loop in microsurgery, we don't want a big tail left behind because that will lead to entanglement. So we take it down until only a few millimeters of suture end are protruding from the end. Then we have to make the loop. Now, if you happen to be using a jeweler's forceps in this hand, the jaws of the jeweler's forceps are very fine, and they can grasp the suture quite easily. However, if you are using a curved needle holder with larger jaws, this will cause difficulties in terms of picking up the end of the suture, and an alternate technique is necessary for making the loop. But now, let's look at the traditional method for making the loop. The left hand turns palm down and grabs the suture, and a loop is formed almost automatically in this way. The right hand should be facing towards the tip of the suture, and it grasps the suture end, making the knot in this manner. And then the second knot is made without letting go of the suture end, and finally the third knot is made in the similar manner. If there is tension on the wound edges, the first knot can be made a surgeon's knot by making a double loop, and this will act as a frictional barrier to spreading the edges apart. Now, there is a problem that comes when you're using the needle holder, as we just mentioned, and in this case an alternate method of making the loop is required. What I usually do is to grasp the suture end with the right hand and make the loop with the right hand and grasp with the left hand, which will be holding a fine forceps. So in this case, what we do is grasp the suture here with the hand palm up or supinated, make the loop over here, wrap it around the left hand instrument, and then pass the square knot in this way. After this, we don't really need to let go. We continue making the loops in a mirror image fashion of the usual way. Grasp it this way, cross the hands, and finally the third knot throw is made in this way. This technique using the right hand to grasp the suture and make the loop, as I said, is helpful when using the needle holder. When using the jeweler's forceps, which is the technique that we will demonstrate most often in the laboratory, we will grasp it and make the knot loop with the left hand. Here's the process close up. If I was using a curved jeweler's forceps in this hand, I would come and grab the suture with my left hand pronated or palm down, grasp the end of the suture, make the first throw, the second throw, and finally the third throw. On the other hand, if I was using a curved needle holder in this hand, I would grasp the suture with my hand palm up, make the first loop, the second loop, and the third loop in this manner. Now let's do some microsuturing. Here we are under the microscope, and notice that the cut in the glove latex runs from away from me on the left to towards me on the right. This is the easiest position to start suturing since it's the most natural one, and this is the position the glove cut should be in when you begin suturing. Now the first step is picking up the needle. Now for the experienced microsurgeon, the needle can be grasped rather easily with one hand. However, when you're first starting, it's a very frustrating chore to pick up the needle. In order to simplify this, as we discussed before, it's helpful to stabilize it with the end of the suture, and then the needle can be grasped about 2/3 of the way from the end. Now you don't want the needle to be too close to the tip of the jaws because it might easily jump out. So we do want it a little bit back from the edge. Now let's go to suturing. We're going to zoom in to show the end of the latex glove here, and we want the sutures to be equally spaced from one another. The first step is to place the left hand forceps, which in this case is a number 2 jeweler's forceps, underneath the edge of the latex. Spread the tips a little bit, and then coming back from the edge about 1 to about 3 needle diameters, we pass the needle, and this everts the skin edge quite nicely. Now we come straight across. We don't come obliquely across. We come straight across, and we use the forceps in order to stabilize the other side, and we pass the needle in this fashion. Notice that this side may be a little wider than this side. You should try to make the two sides about equal distance from the edge in terms of the bite. Now let's zoom out, and we will look at how we retrieve the needle here. Grasp it from the edge. Don't grab the very tip of it, or you can damage the fine point on the microneedle. We grab it and we gently supinate or turn our hand palm up as we rotate it and use the curve of the needle so that we don't tear the tissue. Now when we're pulling it out, we just pull it straight out and let the needle fall. Now notice that we don't have too much suture material protruding. You don't want to leave a big tail, because then it'd be difficult to tie. When you tie, it's going to get caught in the loop like this. We only want a little bit of tail protruding. And because I'm using the curved jeweler's forceps, we're going to use the left hand to grasp the suture material to make the loop. So we grasp it over here, we make the loop. Now notice I grasped with my hand palm down so that the suture comes this way. If I turn my hand the other way and grasp with it palm up, it is usually more difficult to make the loop. So we always grab it with the hand palm down. We make the loop, grab the end of the suture, pass it through, and in this case it lay down quite nicely. If there's a tendency for the edges to spring apart like this, well then we can do one of two things. Either we can make a surgeon's knot on the first one and grab that and lay it down that way, and that will snug it down quite nicely. Or there's another technique that we'll show in a minute that can be used in order to lay the knot down and keep it from separating the wound edges. Now let's go over some of the details of actually grasping the suture end here. Okay, when we make the loop, we don't want to have the right hand instrument all the way over here and then pass it over to here. There's a lot that can go wrong in the process, such as the loop falling off the end of the instrument. What we'd like to do instead is first have the instrument pointing right towards the end of the suture. Then we make the loop, and all we have to do is open the forceps and grasp it. And there we are. Same thing when we grasp it on the second throw. Again, have it pointing down, and we grasp it, pass it through. And finally, on the third throw, we grasp it and pass it through. Usually 3 throws should be sufficient. If necessary, occasionally a 4th throw is required. What we then do is we cut the end of the suture and we discard the loose end here away from our field so that it doesn't get in our way. Now let's look at an alternate way of tightening the knot when the edges are a little bit gapped open and they tend to spring apart, aside from using a surgeon's knot, which is my preferred technique. But this is a nice technique also. What we do is we grasp the end, we make the loop, grasp the end of the suture, and we do not tighten the first throw. We leave it loose. On the second throw then, we grasp it, and now don't pull with your 2 hands together, only pull with the right hand. This will allow the edges to slide together like this. Now when you've reached the desired tightness of your ends, then bring the hands perpendicular to the wound edge, and this will cinch the knot down. Following this, a 3rd throw is required. Now notice, here the end is a little bit too long. Watch what happens if I grasp it here and the end is left too long. See, what happens is it gets hung up in the loop, and it ends up making a slip knot out of it, which then you need to fumble with to get out. That's the reason for leaving the end shorter than longer. But this is a nice technique of approximating the edges when there is some tension. Now we're going to demonstrate using the needle holder instead of the curved jeweler's forceps to pass the needle. Again, we pick up the end of the suture in order to grasp the end of the needle. We will pass it in the usual manner, about 3 needle diameters away from the edge, everting the edges nicely, and we'll gently pass it through this way. Now, one of the reasons to use the curved needle holder to begin with for training purposes is that this can sometimes squeeze the needle too vigorously and bend it, or injure it, and we do not want to pick up the needle by the end, because that will certainly damage the end of the needle. Now, the difference in terms of tying is that instead of using the left hand and making the loop around the right instrument in this way, what we'll do is we're going to hold the suture here with the right hand and make the loop around the left instrument. This may seem like a trivial point, but the problem occurs in clinical microsurgery when this end is plastered down to tissue. It's very difficult to pick up the end sometimes using the needle holder, or even to make the loop using the needle holder, so it's much easier to make the loop around the fine jeweler's forceps. So what we do is we turn my right hand, palm up, grasp the end of the suture here, make the loop, pass it, make our first throw, do not let go of this, of the right hand, make the second loop, and see how easy it is to pick it up using the left hand. Now we use our technique here to tighten the edges down there, and finally a third throw completes it. Now once you've mastered the art of sewing with the cut pointing this way in the glove, the next challenge is to change the position of the glove. And what we usually do is we turn it horizontally and start sewing towards yourself. This requires a slight change in hand position, but not very much compared to the first. Once you've mastered that, the next step is to point it so that it is going vertically. And this also requires a slight change in hand position, but not very much. The most difficult part is to sew with the obliquity facing this way, opposite from the initial one. And in this position, it's hard because you either have to squinch your hand around this way and sew this way, or you have to completely turn your hand opposite and sew this way. Now, in order to get around that, a very simple technique is to change the way the needle is loaded in the forceps. And in order to do this, what we do is we load the needle backhanded, so-called backhand position, which is just like this. And then in this way, the jeweler's forceps comes around the opposite way, and you pass the needle in a backhand manner, otherwise using the same technique. And this will afford you a much easier time when sewing the glove when it is facing this direction. Because unfortunately, in the operating room, we can't always rotate the patient in the position we would like them to be. Well, now that you've mastered suturing on the latex glove model, it's time to move on to animate objects. Our next videotape concerns microsuturing on the rat femoral artery, which is a bit more challenging than suturing glove latex. If you have any questions about your ability, go back and practice more on the glove before moving on to the next videotape.
In this tape, I'll show you every step and every pitfall in the deceptively simple process of basic microsuture technique. We'll look in detail at picking up the needle, passing it through the tissue, pulling the thread through, and last but not least, tying the knot. As we go along, we'll take a close look at all the common causes of frustration, entanglement, and despair, and we'll see how these can be avoided. There's a lot of information on this tape. I'll suggest about halfway through that you switch off and take a break so you don't get too overloaded. Throughout this tape, the instructions are for a right-handed person. If you're left-handed, you might prefer to watch it using a mirror. Let's take a look at tools and materials. Here are the instruments you'll need. A pair of scissors with fine pointed tips for cutting the suture, a straight jeweler's forceps for your left hand with tips that meet nicely like this, and an angulated jeweler's forceps for your right hand. The angulated jeweler's is both a needle holder and a tying forceps. The material we work on is a piece of regular surgical glove rubber stretched out under very slight tension. Cut it with a knife and you've got a wound to stitch. If it pops open like this, the rubber is stretched out too much. You'll need to slack it off a little, or you'll have more tension than you can deal with. We use a clinical grade suture material that's packaged for laboratory use. It's 10-0 nylon on a sturdy 140 micron needle. 12 centimeters of thread is all you need. If there's more, cut it off. Now let's get down to business, picking up the needle. In the exact way that you pick it up, you set yourself up either for success or for frustration. Here are just some of the highly avoidable problems that can arise if you don't pick it up correctly. There are 4 things, no less, that need to be just right each time you pick up the needle. First, you need to pick it up with the right part of the needle holder. Second, you need to pick the needle up at the right point along its length. Third and fourth, the needle must sit at 90 degrees to the needle holder, both in this plane and in this plane. Let's look at each of these points and see why they are important. The first point, use this part of the needle holder. If you hold the needle too far back here, you'll destroy the curve of the needle. If you hold it too close to the tip, with just a little extra squeeze, it'll flip out of there, just like this, and never be seen again. Now the second point. Pick up the needle somewhere between here and here. That's in the middle half of the needle. If you go beyond those limits, you'll either have so little projecting that you can't do anything with it, or you'll be holding the soft channel end of the needle, which bends very readily. Within these limits, the exact spot that you choose determines the upward or downward angle at which the needle will approach the tissue. Holding it back here gives the tip an upward tilt. Holding it in front here gives you a downward tilt. And holding it right here puts the needle tip parallel with the tissue, which is what you want, especially when you're starting out. In vessel surgery, you particularly don't want a downward tilt. That's a sure way to hit the back wall, and that's a disaster. Now the third and fourth points. Holding the needle squarely in both this axis and this axis is important because that's the only position in which it'll hold steady when you push it. If you have it tilted on its horizontal axis, when you push it, it'll capsize. If you have it rotated in its vertical axis, the same thing will happen. Hold it square in both planes, and it'll go where you want it to go. Now that we've seen what's important, let's see how to pick the needle up just right. There's a way that works every time. Resist the urge to go after the needle with the right hand instrument. Instead, start with the left hand instrument and use it to pick up not the needle, but the thread. Pick it up here, about 2 centimeters from the needle. Now, lift the thread straight up and dangle the needle so it just touches the flat underlying surface. By moving the thread around, you can make the needle point in almost any direction. In this way, get it to point roughly in the direction you want, which is toward the bottom left. Now you're ready to pick it up. Just a point of detail. As you pick it up, touch the needle first with the near jaw of the instrument. That way it'll go on pointing where you want. If you touch the needle first with the far jaw, it's easy to knock it out of position. Once you've picked the needle up, if you find it's tilted on its horizontal axis, you can correct that by giving a light touch here or here with your other pair of forceps. You can also correct malrotation in either plane by this simple maneuver. Let's see that again. Touch the underside of the needle on the underlying surface and drag the needle backwards while momentarily slackening your grip. Here are a couple of mistakes to avoid in picking up the needle. The first, as I've mentioned, is to come at the needle first with the needle holder. That usually leads to quite an unsatisfactory pickup. The second mistake is to try to correct such a malrotation by working on the needle with both pairs of forceps at once. That tends to make a bad situation worse, and you can end up with your patience diminished and your needle sadly modified. Remember, pick the thread up first. One last thing to mention about picking up the needle is magnetization. If this or this keeps happening, it's because the needle holder or the instrument is magnetized. Demagnetize both the instrument and the needle at the same time in a coil demagnetizer, like this. Switch on, withdraw the instrument, switch off. So much for picking up the needle. Now let's look at passing it through the tissue. When you first begin, work in the direction that's easiest for you in terms of your hand position. That's with the needle pointing from top right to bottom left, like this. Make sure your hands are sitting firmly on the table, with the fingertips supported. Now put the microscope up to high magnification so you can really see what you're doing, and stay at high magnification till you've finished passing the needle. Bring in the needle and pick the spot where it's to enter. The distance between the entry point and the edge of the tissue should be about equal to the thickness of the tissue. Now come under the tissue edge with the left hand forceps and raise the tissue up toward the needle, everting the tissue at the moment when you push the needle through. Do not let go of the needle at this point. Move the needle tip to an exactly matching exit point on the other side. Bring the left hand forceps in from above and press down toward the needle, again everting the tissue as the needle goes through it. Here's what you're aiming to produce: 2 equal-sized bites with the needle crossing the wound at 90 degrees. When that's tied, the underside will look like this, nice and flat. The next action will be to pull the needle through, but before going on with that, we need to spend a few minutes looking first at some potential mistakes in passing the needle, and then at some important do's and don'ts in the matter of tissue handling. This would be a bad stitch. The bites are unequal. When that's tied, one side will overlap the other, and this tissue edge will be exposed to the bloodstream. In blood vessel surgery, that's bad news. Here's another bad stitch. The needle has crossed the wound obliquely instead of at 90 degrees. When that's tied, the long edge will pucker. See right here? And again, you'll have exposed tissue. Here's a third bad stitch. The 2 bites are just too big. If you do a series of those, you'll get complete overlapping of the edges. Remember I said don't let go of the needle between going in and coming out? If you do, your efforts to regain control of the needle will likely lead you into a struggle like this. In delicate vessel tissue, that kind of struggle can enlarge the needle hole, and that's bad news. I need to mention some do's and don'ts concerning the way you handle the tissue with your left-hand forceps. Using the left-hand forceps as a counterpressor is a nice atraumatic method, which I strongly recommend. 2 other methods are useful in vessel surgery: picking up the adjoining stitch and picking up the outer layer of the tissue. That's a lot easier on vessel wall than on rubber, because you have the adventitia to hold on to. One way not to pick up the tissue is to grab its full thickness like this. If you do that to real vessel wall, you'll cause serious harm. Now that we've looked at all those potential mistakes, let's get back to where we were. You've put the needle tip in and brought it out. Now you have to pull the length of the needle through. Remember, pulling is more controlled than pushing. Pull the needle through with 1 or 2 straight pulls so that its tail end rides cleanly through the needle hole. avoid pulling it sideways. That's very traumatic. If you do that on a blood vessel, here's what you'll get: a hugely enlarged needle hole. Once you've got the needle through, you no longer need high magnification. In fact, it would be quite a nuisance to continue with it. Turn the magnification down before continuing. Now, to pull the thread through, pass the needle to your left hand forceps and make a long, steady movement with the left hand while carefully watching for the end of the thread. When the end comes into view, stop pulling and drop the needle. Where it lands doesn't matter, as you'll see when we've tied the knot. There are two things to avoid in pulling the thread through. The first thing to avoid is to have the thread coming through the tissue at an angle like this, rather than in a straight line like this. It's dangerous to have it running at an angle because with just a little drag on the thread, that angulation makes the thread tend to cut through the tissue. Glove rubber may withstand this, but a blood vessel won't. To avoid this problem, use your right hand forceps whenever you need to as a pulley so that the thread passes cleanly through the tissue in a straight line. The second mistake to avoid on pulling the thread through is to bring the needle and a whole lot of thread with it back into the field of view before you tie the knot. This complicates the picture enormously, just when you'd prefer it to be simple. We've looked at picking up the needle, passing it through the tissue, and pulling the thread through, and we're about halfway through this tape. At this point, I'd like to review some of the classic pitfalls that I've already mentioned. First, in picking up the needle, avoid these mistakes. Picking it up with the wrong part of the needle holder, or at the wrong point on the needle, or at an unstable angle. Avoid picking up the full thickness of the tissue. Avoid taking bites that are too large, or bites that are unequal, and avoid passing the needle obliquely. Also, avoid letting go of the needle halfway through. In pulling the needle through, avoid a sideways pull on the needle or on the thread. Having pulled the thread through, avoid bringing the needle back into the field of view. Lastly, avoid using the wrong magnification. If you have it too high when you're picking up the needle, or too low when you're going through tissue, or again too high when you're pulling the thread through, you just can't do the job. I've given you a lot to remember already. Let's stop the tape and take a break. Now let's look at how to tie a knot. Tying a knot looks so simple. Why is it that when you first try it, this happens, and this, and this? You'll be glad to know that scenes like these are not a necessary part of the human condition. There are some simple tricks that'll make knot tying easy for you. By far the biggest trick is to set yourself up for success before you pick up the thread, both with your left hand forceps as you begin and with your right hand forceps when you're halfway through. I'll explain this in full as we go along, but first let's look at the 4 separate acts which make up the tying of a simple half knot. It's useful to consider each of these separately. Here they are. First, you pick up the thread with your left hand forceps. Second, you make a loop of thread on the tip of the right hand forceps. Third, you pick up the end of the thread with the right hand forceps. And fourth, you pull the end of the thread through the loop. Let's look at each of these acts and see where the problems arise. Act 1. Picking up the thread. Be sure at the start that you have the right amount of thread to work with, both here, that's the short end, and here, that's going to be the loop. If the short end is too short, you're likely to pull it through by mistake. If it's too long, you'll have trouble pulling it fully through the loop. 3 millimeters is a good length for the short end. That's a little shorter than the tip of these angulated forceps. For the loop, you need a length of thread about 3 times as long as the short end. If the loop is too short, again, this happens. If it's too long, you can't work with it concisely, and you'll have to make oversized movements to get it to behave. Let's get back to the action. Here you are, all ready to pick up the thread, and now I'm going to tell you the first big trick. Watch carefully. Pick the thread up the right way round, like this, not like this. There's a spectacular difference. When you pick it up like this, the thread that's going to be the loop emerges from the side of your forceps which you can't see. That's the side which faces away from where the knot is going to be. The thread which faces that way will strongly resist your efforts to turn it into a loop. If you do make a loop with it, it'll try hard to fall off your forceps. Most frustrating. By contrast, when you pick it up like this, the thread that's going to be the loop emerges from the side of your forceps which you can see. That's the side that faces toward where the knot is going to be. When it faces that way, it'll have a strong urge to become a loop, and once you've made the loop, it'll be quite willing to stay on your forceps. Because this is such an important point, let's look at some real-life situations. This is right. Look how easily that loop was made. This is right too. The loop almost makes itself. But this is wrong. Look at this hassle. And this is wrong too. When you pick the thread up the wrong way round, it just refuses to be made into a loop. Always arrange for the thread that's going to become the loop to emerge from the side of your forceps that you can see. That way you're working with the thread instead of fighting it all the time. Believe it or not, about half of all the problems that people experience in knot tying arise from that one simple problem in picking up the thread. As you practice, you might want to create the problem for yourself deliberately, just so that you can experience the frustration for yourself. So much for Act 1. Now for the second big trick. Before you start on Act 2, which is making the loop, you need to set yourself up so that you'll easily be able to perform Act 3, which is picking up the short end. Let's look at the potential difficulty. It's a matter of where the thread is pointing and where your forceps are pointing. The short end of the thread may be pointing north, south, east, or west, and it may be lying down flat or sticking up in the air. Your forceps also may be pointing in any direction. If the thread is sticking up in the air, there's no problem. You can get hold of it readily, no matter what direction your forceps are pointing in. But if the thread is lying down, you can only pick it up if the gap between the tips of your forceps is in about the same plane as the thread. If the plane of your forceps is at right angles to the line of the thread, there's no way you can get hold of it until you turn your forceps around. Here's the struggle I get into when I fail to anticipate that problem. My thread is lying in such a direction that I won't be able to pick it up. Disregarding that, I go ahead and make a loop, and it's then that I find that I can't pick up the short end. I try the same move several times just to upset myself. Then I belatedly figure that I have to change the direction of my forceps, and in my efforts to make that gross movement, either I pull the short end through, or the loop falls off the forceps. Here's how to avoid these problems. First, look and see if you'll be able to pick up the short end. If not, then make the necessary adjustment so you can pick it up. Then make the loop. Then pick up the short end. That's the second big trick. It's really that simple. Now that we've previewed Act 3 so thoroughly, let's go back to Act 2 and look at making the loop. Bring the left hand forceps toward the site of the knot, and at the same time bring the tip of the right hand forceps down over the loop length of thread. Curl the right hand forceps round the half-formed loop, and the loop is made. Just a few points here about making that loop. First, as with all instrument ties, be sure that you have the right hand forceps pointing away from the site of the knot. If you point them toward it like this, you get a loop that doesn't have the necessary twist at its base, and you end up with no knot at all. Another important detail, if you come as I showed you from above the thread and make your loop this way round, you'll end up with a half knot which lies flat, and that's the first step toward a good square knot. If instead you come from below and make the loop the other way round, you'll get a half knot that lies awkwardly, and you're likely to end up with this instead of this. There are 3 mistakes in loop making which all result in the loop falling off the forceps. The first is to make the loop too tight. The second is to have it perched too close to the tip of the forceps. Here's what you want, a loose loop back here on the forceps. You can guide it there if you need to by pulling with the left-hand forceps, like this. The third way to lose the loop is to make it somewhere far away from where the knot is going to be, and then make a journey with the loop poised on the forceps. In the course of the journey, it's easy to lose the loop. In addition to losing the loop completely, there's a strange problem that arises if the loop ever falls just halfway off the forceps like this. If you don't notice what's happened, you go ahead with Act 3, and when you get to Act 4, the loop won't come off the forceps because it's trapped. If that happens to you, you'll know what went wrong. Let's just see what happens in loop making when you have your right-hand forceps pointing in a few different directions. It's the same sequence every time. Come down on the thread, get the loop started, curl the instrument around it. Come down on it, get the loop started, curl around. It's always the same set of actions. That's it for Act 2. As for Act 3, I've told you about that already. Provided the tip of your forceps is pointing in the right direction, there's nothing to it. Just pick up the thread and move straight on to Act 4, pulling the short end through the loop. Pull the short end across the wound in one direction and pull the loop length across it in the other direction, and your half knot is complete. 3 things to notice here. First, you do cross your hands over, or rather your instrument tips, as you complete the half knot. Don't let that upset you. Second, you don't attempt with the first half knot to bring the wound edges together. That's a waste of time at this stage. We'll talk about the final tightening in a moment. Third, having completed the half knot, you definitely do not let go with your left hand, because from this position you lead straight into your second half knot. Well, it seems it took a long time to talk about making one half knot, but I hope you'll find it easy. Let's look at the sequence one more time. 1, 2, 3, 4. When you've practiced it for a while, it'll go just like this. Now for the second half knot. Since you didn't let go with your left-hand forceps, you can go right into the second half knot without a break. Check that you can get the short end, change position if you need to, make the loop, pick up the short end, pull it through. I know what you're thinking, just tighten the knot. I will, but there's a problem in getting from here to here. This is what happens. You pull on the 2 threads, and before you get the wound edges together, the knot closes up and locks, and you don't want that at all. There are 2 ways to avoid this problem. The first is to make a surgeon's knot with a double loop on the first half knot. That's good, but when you're first starting out, a double loop can be quite troublesome. The second way to avoid premature locking, which doesn't call for a double loop, is this. Instead of pulling upwards on the 2 threads at the same time, pull sideways, first on the short end, then on the long end. Let's see that again in slow motion. Leaving the long end slack, pull sideways on the short end till the first half knot comes just tight enough. Then pull the long end over and tighten the second half knot. There's your square knot completed. Put one more half knot on top of it for security, and the job is done. To get ready for your next stitch, cut the short end first, then the long end, and then pull on the long end to bring your needle back into view. then, finally, let go the thread. I hope you've noticed that from beginning to end you don't need to let go of the thread with your left hand forceps, from the moment you first pick up the thread to the moment when you finish tying the knot. Just watch that left hand forceps. It goes on holding on. It's when you've dragged the needle back into view that you finally let go your hold. That's important. If you're constantly letting go and picking up, you're not only wasting time, you're also putting numerous kinks and points of weakness in the thread. Throughout this tape, I've been working in the direction that's easiest for a right-handed person. That's with the needle passing from top right to bottom left. That's the best direction to use when you're first starting out. But in clinical surgery, you'll need to be able to suture in any direction. Once you've thoroughly mastered the basic moves, you can say goodbye to the easy position. Turn your practice piece round and learn to do good work in these different directions. Straight up and down, straight across, and backhand. This is the hardest position to master. Learn to do good backhand stitches, passing the needle not only toward yourself, but also away from yourself. Lastly, practice being ambidextrous. Convince your non-dominant hand that it can be a successful prime mover, and convince your dominant hand that it can sometimes just be the helper. We're almost at the end of the tape, so let's just review the most important points from the second half of the tape. Arrange just the right length of thread for the short end and for the loop. Always pick up the long end so that the loop length emerges from the side of your forceps that you can see. Before making the loop, set up the direction of the right-hand forceps so that with the loop made, you'll have no problem picking up the short end. Finally, use the sliding maneuver to avoid premature locking. Well, that's it. We've covered basic microsuture technique. As you practice, try to remember what I've told you already on the first tape in our series, Preconditions of Microsurgical Skill. In particular, remember about avoiding fatigue and frustration, avoiding unwanted movement, and achieving good hand position. As you practice, if you find you're experiencing a particular problem, don't hesitate to come back and watch this again. Before we get started on this important and basic exercise of anastomosing an artery, let's first get acquainted with the equipment and instruments which you'll be using throughout the laboratory course. First, here's the rat. He's anesthetized with intraperitoneal Nembutal. The rat board is made of a piece of cork-covered bulletin board. The rat is fastened to the board with tape and push pins. A piece of tape goes around each limb. The tail is also fastened. When the rat is laid out on the board, the pins should be put close to the limb, not far away like this. When it's like this, you get too much movement of the limbs. The four limbs should be spread out gently with the pins, not at full stretch like this. When they're like this, the vessels will be under a lot of tension and the rat will have difficulty breathing. The anesthetic syringe connects to a scalp vein cannula which runs into the peritoneal cavity. A dose of anesthetic takes up to 5 minutes to take effect. The rat will need a little more anesthetic about every 45 minutes. Be careful. It's easy to overdose a rat. Don't give more than half a cc at a time, and don't give any unless you're certain that the rat is getting light. To see if the rat's getting light, push on one of his front paws. If he wriggles like this, he's light. If he doesn't, he's not. When a rat makes a croaking noise, it doesn't mean he's light. It means his airway is obstructed and needs to be cleared in a hurry, which you do like this. Now let's look at the rest of the equipment which you'll need to have on the table before you start to work. You have a bipolar coagulator, syringes of Ringer's solution for irrigation and xylocaine for vasodilatation, some 4x4 sponges for general purposes, a suction line, and a good basic instrument set. Let's just take a few minutes to look at each of these instruments in turn. We start the procedure with a regular scalpel with a number 15 blade, a pair of fine-toothed forceps, and a pair of straight dissecting scissors. These three relatively crude instruments are only used for the initial incision and early dissection. We then proceed to dissect the vessel out using these two instruments, a straight jeweler's forceps and a pair of microsurgical dissecting scissors. The tips of the jeweler's forceps must meet very exactly. The dissecting scissors are curved and are quite rounded and fat at the tips. In dissecting out the vessel, we also use a bipolar coagulator with fine-tipped forceps and foot pedal control. Once the vessel is dissected out, we apply this approximator clamp to it. The two clamps slide along the bar. The clamp is applied with this clamp applicator forceps. The very tips of the applicator jaws fit into the grooves at the end of the clamp blades. In preparing the vessel ends, we use a vessel dilator and a pair of adventitious scissors. The vessel dilator has fine, polished, non-tapered tips. The adventitious scissors are straight and very sharply pointed. Notice the difference between dissecting scissors on the left and adventitious scissors on the right. In suturing, we use this angulated jeweler's forceps as our needle holder. Last but not least, we need a couple of these simple retractors and a small piece of dark-colored background material to go behind the vessel. If you're all set, we'll get going. We'll be taking another break in about 15 minutes once the vessels are clamped and divided. In the course of this tape, I'll sometimes show you the wrong way of doing something. When you see this, you'll be watching a wrong action being demonstrated. And when you see this, you'll be watching the results of that action. Okay, let's get started. If you're right-handed, start on the rat's right leg. It's easier. The vessel you'll be working on is the common femoral artery, right up at the top of the leg. Its distal continuation, the superficial femoral, shows up beneath the skin lower down the leg, but the vessel you're going for, the common femoral, is here. It lies beneath a pad of fat, the inguinal fat pad, which covers this area. To expose the vessel well, you need a good big incision at right angles to the vessel. Put the incision right in the hollow between the abdomen and the leg. With the knife, cut through the skin, but don't go any deeper. With your fingers, use a little force and pull the wound edges apart. What we're seeing is the inguinal fat pad. There's a big branch vessel in the fat pad, the epigastric. It arises about here, runs up into the fat, and goes off in that direction. You'll be saving that vessel. The best way to get the fat pad out of the light is not to cut through it, but to cut round it, from here right round to here. You'll see why this is good in a minute. Pick up the fat at the medial end of the wound, lift it up, and cut right through it. Keeping your scissors away from the underlying muscle, cut through the fat all along the top edge of the wound and all along the bottom edge of the wound. Now you've cut around the fat pad, you need to mobilize it so that it'll swing right out of the wound. So pick it up medially, pull it laterally, and start dividing these filmy adhesions which lie beneath it. Right away, you'll see the common femoral vessels. There they are. And next, you'll see the epigastric, right here, running up into the fat. Keeping the epigastric intact, go on dividing adhesions above it and below it till the fat pad can be swung right out of the wound. Here's why it's good to mobilize the fat pad in this way. Right at the end of the procedure, when you take off the clamp, you'll be able to take that fat and press it on the vessel to stop bleeding from the anastomosis. For the present time, put the fat pad out of the way and keep it out of the way by placing a moist sponge over it. The last act of gross dissection is to separate the abdominal wall here from the upper thigh here, thus exposing the upper part of the femoral vessels. Put a retractor in the abdominal muscle and pull it upward and medially. Divide the adhesions which lie in the way of your exposure and continue until this white band comes into view. That's the inguinal ligament, and that's as far as you need to go.
You've been working naked eye up to this point. Now it's time to bring in the microscope.
Your hand position will be much more comfortable if you put a couple of folded towels here and here to rest on.
Now you're going to dissect out the artery. The key to dissecting out this artery and every other artery you'll ever dissect is first to recognize the vascular sheath which surrounds it, then to divide that sheath, and then in a wonderfully easy plane of dissection to separate the sheath from the artery all the way round and all the way along the vessel.
The vascular sheath is a distinct layer of fibrous tissue with vasa vasorum running in it. This loose tissue is not the vascular sheath. Get rid of it. Here's the sheath. You can tell because when you pick it up, the vasa vasorum come up with it. You'll be cutting the sheath from the inguinal ligament to the origin of the epigastric. Since it's easiest to cut from right to left, start right here, close to the inguinal ligament. With straight jeweler's forceps, pick up the sheath. With dissecting scissors, make a small cut in the sheath. Spread the edges of the cut and look through the window you've made. There's the naked artery looking right at you. Now slide one blade of the scissors in between the sheath and the vessel. See how easily it goes. And cut all the way along. In one or two places you'll cut vasa vasorum. You can either wait for these to stop or buzz them with a bipolar coagulator. Go on dividing the sheath till you've gone the whole way along. Now that you've cut through the vascular sheath from here to here, the next job is to get the vessel out from inside it, staying in just the same plane of easy dissection. First, free up the far side of the vessel. Pick up the vascular sheath, pull it sideways, and divide the loose fibrous tissue which holds the vessel and the sheath together. Concentrate on staying in just the same plane of dissection. Now free up the near side of the vessel. Pick up the artery by the adventitia and pull it out sideways. Divide the loose tissue which holds the artery and vein together. As long as you stretch those fibers out, you can see them easily and cut them safely.
If you can see it well, you can do it well. If you can't see it, don't do it. I'll be backtracking in just a minute to talk about the proper use of forceps and scissors. But first, let's get the freeing up of the vessel completed. You've cleared the far side and the near side of the vessel, so now just the underside remains to be freed up. To get at the underside, pull the vessel sideways and a little upwards. It's very nearly free now. Just divide this little web of tissue and it's free altogether. A feature of the underside of the vessel which you can't ignore is this fat branch which always arises right around here and runs directly away from you. It's called Murphy's branch, and you'll be dividing it in just a minute. Meantime, treat it with respect and complete the dissection above and below it till the vessel lies completely free from the inguinal ligament to the origin of the epigastric. Now it's time for a digression about instruments. I really need to talk about the proper use of these two instruments, your jeweler's forceps and your dissecting scissors. First, the jeweler's forceps. Whenever you use the forceps to pick up the vessel, pick it up like this, by the outer layer, the adventitia. Don't ever pick it up like this, by grabbing the full thickness of the vessel wall. That's a bad breach of atraumatic technique. It really damages the media and intima. Remember, use the adventitia always as the good, safe handle that it truly is. If your forceps won't pick up the adventitia, there's something wrong with them. Either they're dirty or they're bent. Clean them, fix them, or get another pair. But don't go on using a pair of forceps that doesn't do the job it's supposed to do. Now a few words about the use of scissors. Doing a good clean dissection on a vessel means working close to the vessel with your scissors. Don't be scared about this. Be safe. There are 3 good rules of safe conduct. First, for preparatory dissection, always use proper dissecting scissors with round tips like these. Never use sharp-tipped adventitious scissors for this part of the work. If you do, you'll find this happening to you with monotonous regularity. Second, keep the tips of the scissor blades flat against the vessel as you cut. Don't hold them at an angle like this. If you do, you'll very soon make a hole. Third, only cut where you can see. See it clearly, cut it safely. If the field is obscured by blood, don't cut. If your view is out of focus, don't cut. If you're working in a blind corner, don't cut. Remember, it's the last stroke of the scissors that leads to disaster every time. These seemingly small details about the way you use your instruments really do matter. Now, let's get back to the action. It's time to divide Murphy's branch. Make sure the branch is dissected free for a short distance. Take a short piece of 10-0 nylon, pass it round the branch, and tie it tight. Now, rather than tying it a second time, take the bipolar coagulator forceps and cook the little branch gently but thoroughly. Then divide it with scissors. If you're not sure of the correct setting for the bipolar, try the forceps on a piece of unimportant tissue nearby. This is too weak. This is too strong. This is just right. Now that the vessel is finally and fully mobilized, the next step is to take the piece of plastic background material and put it beneath the vessel. This makes the vessel ends easier to see once they're empty of blood. It makes a real difference, as you'll soon see. If you're having a battle getting the background material under the vessel, either it's too big or you didn't mobilize the artery well enough. Either way, do something about it. Don't sit there struggling like this. Now you're all set to put the double clamp on the vessel. As you put the clamp on, think ahead. Here's what you want to get for yourself. 2 nice long vessel ends which you can work on easily. Here's what you don't want. Little short ends like this. It's hopeless to try to work on vessel ends like that. So set yourself up for success right now. Slide the 2 clamps apart about as far as they'll go. Put the clamp applying forceps on one of the clamps, open the clamp, lift up on the vessel, put the vessel right at the tip of the clamp, and close the clamp. Now open up the other clamp and put the vessel in it. Just before you close the clamp, lift up on the vessel between the clamps so that you get plenty of vessel length in between the clamps. There are 2 things to be careful of when you're putting the clamps on. First, there must be this much freely dissected vessel length both above and below the clamp so that the clamp can be turned over freely without hurting the vessel. If you didn't mobilize the vessel well, your clamp will go on like this. And when you turn the clamp over, you'll hurt the vessel badly. It's the difference between this and this. That hurts. The second detail about putting on the clamp concerns Murphy's branch and where to put it. The thing you don't want is to end up with the branch lying just off-center between the clamps, because then you'll have this stump right in the way where you're stitching. What you do want is to end up with the branch either here, right in the middle where you can easily excise it, or here, right at one end, where it won't be in the way at all. Now you're ready to divide the vessel. Hold it still and cut across it. If Murphy's branch is right there, cut across the vessel again and get rid of that piece of the artery. Now that you've taken a break, let's pay close attention to the preparation of the vessel ends. This is done in 3 stages: getting the blood out, trimming the adventitia, and dilating the vessel ends. Trimming the adventitia is the most important step, but getting the blood out comes first. To see how that's done, let's go back to where we were. As soon as the vessel is divided, take your syringe of Ringer's solution and bring the point of the needle into view. Pick up the vessel end so it faces the needle and squirt the blood out. Make sure it's all out. Do the same to the other vessel end. You need to get on and do this in the first half minute after you cut the vessel. If you don't, the blood will clot right at the vessel end like this, and you'll have a hard time removing it. Now, trimming the adventitia. Let's look at the adventitia and see what it is that you need to do. This is the adventitia hanging over the end. This is the media, which is what you put your needle through when you put in sutures. See how the adventitia can be slid back and forth. You've got to trim off the whole of this cuff of adventitia so that the vessel end looks like this. Here's why this is important. If you start with 2 clean, tidy, well-trimmed vessel ends, you'll find it quite easy to make an anastomosis which looks like this, and works perfectly. If you start out with poorly trimmed vessel ends like these, your finished anastomosis, after a long and miserable struggle, will end up looking like this: a mess and a failure. With well-trimmed vessel ends, you can see with every stitch just what you want to see, and do, with every stitch, just what you need to do. With badly trimmed vessel ends, you can never see what you need to see, and you never know with any stitch whether or not you've done what you meant to do. Now here's how the trimming is done. With the straight forceps, pick up the adventitia right at the vessel end at the point that's nearest to you and pull it off in this direction. You can see where you're going to cut it. The media is right here and you're aiming to just miss that. Still pulling with the forceps, take the sharp-pointed adventitia scissors and cut through the adventitia right there. You've done it, part of it. Now you must go on round the vessel end. Pick up the adventitia here, pull it off, cut through it. Pick it up here, pull it off, and cut through it. Finally, only the far side remains. Pull it off, cut through it. There, you've gone right round. Now, take a close and critical look. Did we really get it all? No, there's a little bit still hanging on. That must go. That's just the kind of adventitial tag that would get you into the worst kind of trouble if it were to drift into the lumen and get picked up by the needle. So, remove it. That vessel end is finally clean. To trim the other end, flip it over backward so that it points in a convenient direction and treat it in just the same way. Two words of caution about trimming the adventitia. First, don't use the dissecting scissors for this job. Their tips are much too bulky. You can't see past them to see what they're doing. Second, keep the scissors in the same flat plane as the vessel end. If we imagine that this black rubber is the media and that this gauze is the adventitia, the important thing is to hold the scissors in the same plane as the vessel end like this, not at an angle and not at a slant. If you have them pointing at some awkward angle, here's what will happen. You'll cut the media, which is just what you don't want.
Trimming the adventitia is a difficult task until you've done it a few times. The first time you do it, you may well end up with a vessel end that's all battered and ragged. If you do, the thing to do is to cut back the entire vessel end and start over. The thing not to do is to pretend you've done a good job of vessel preparation when you haven't, and try to go ahead with the anastomosis with badly prepared vessel ends. That won't get you anywhere. If you decide to cut back the vessel end, you may well find yourself somewhat short of vessel to work on. Here's a safe way to advance the vessel in the clamp.
First, flex the leg to slack off the vessel tension. Then put the clamps as far apart as possible. Then get hold of the vessel end and start pulling on it firmly. Then, for an instant, open the clamp. Clean up the mess, and you're ready to make a fresh start.
If, after repeatedly cutting back and re-trimming, you find that your vessel ends are so far apart that you just can't bring them together and anastomose them, don't feel bad about it. After all, you'll have learned a great deal about trimming the adventitia, and that's an excellent way to use up your first vessel. But abandon that vessel now, ligate the ends, and go to the other side. Start over on a fresh vessel. After trimming the adventitia, the final act of vessel end preparation is to dilate the vessel ends with the vessel dilator.
Pick up the vessel near the very end. Slide the tip of the dilator inside the vessel and separate the tips till the vessel is about 1.5 times its natural size. Close the instrument and bring it out. See how nice and big the vessel is all of a sudden. Dilating the vessel end is a two-handed job, and you must hold on to the vessel here, not here. If you hold it here, this is what happens. The vessel falls off the instrument. If you don't hold it at all, you get just the same trouble. Stretching the vessel wall not only makes the vessel ends bigger and easier to deal with, it also paralyzes the smooth muscle in the vessel wall and so completely prevents the anastomotic site from going into spasm. We haven't put in one suture yet, but I need to tell you that you've already watched most of the important information that's on this tape, because the essential principle in microvascular surgery is preparation. Before we go ahead with suturing, let's just take one final break. Now let's move into the final section, suturing. Just to understand the plan of action, let's look at a diagram. This is the vessel circumference. You're going to divide it into three with three equally spaced stay stitches. Then you're going to put a couple of stitches here, a couple here, and a couple here to finish the job. That's the principle. Now, here's the actual sequence of events. You start off by putting in just the first two stay stitches and pulling them in opposite directions. Then you put two regular stitches in between the stay stitches, and the top third of the anastomosis is done. Then you turn the vessel over and put in the third stay stitch. You pull the third stay stitch over to one side and put two regular stitches in here. Then you pull it over to the other side, put two final stitches in here, and the job is done. So you're going to put in 9 stitches. Here are the requirements for consistent success. Each stitch must be well placed. Each stitch must be well spaced. And each stitch must do its share of fair and equal coaptation of the vessel ends. Let's be quite clear what's meant by placement, spacing, and fair coaptation. Placement refers to the size of bite you take. These bites are too small. These bites are too big. These bites are uneven. These bites are just right. Spacing refers to the distance between one stitch and the next. These stitches are too close together. This stitch is too far from its neighbor. These stitches are unevenly spaced. These stitches are just the right distance apart. Fair and equal coaptation refers to the accurate division of each vessel end, first into thirds, then into ninths. We have to bring a third of the circumference of one vessel end into coaptation, not with a quarter, not with a half, but with an exactly matching third of the circumference of the other vessel end. Again, when you pick up a ninth of the circumference on one side, you must choose your exit point so that you pick up not a 12th, not a 6th, but just a 9th of the other side. You'll soon see that accurate placing of the second stay stitch is the most important single step in securing fair and equal coaptation of the whole vessel circumference. In addition to being well placed, well spaced, and doing a good job of coaptation, each stitch must also be tied with just the right degree of tightness. This is too tight. This is too loose. This is just right. Finally, with every stitch you put in, you must avoid the fatal mistake of picking up the back wall and producing a through stitch. We'll talk about that in a while. Right now, let's go ahead with the actual suturing. The easiest place to put a stitch in would be here, at the point closest to you. Keep that easy spot for your most difficult stitch, the second one. Put your first stitch over here. First, put the tips of your forceps just inside the vessel. Then, choose your spot, pass the needle, pull it through, and pick it up again. Looking at that action again, notice that the left-hand forceps do two important things. First, they show you where the lumen is by clearly separating the front wall from the back wall. Second, they support the vessel wall as you push the needle through. Now for the other side. Pick up the vessel end near to where the suture is to come out. Lift up on it a little to show yourself the lumen. Then put the needle in the lumen, pick your spot, and pass the needle through. Let's watch that again. The left-hand forceps do the same two jobs as before. They show you the lumen clearly, and then, moving to a slightly different spot, they hold the vessel wall steady as the needle goes through. Now to tie the knot. Pull the thread through and make the first half knot. Tighten it cautiously. Will the ends come together comfortably without tension? Yes, they will. Now make the second half knot. And the third. You saw the vessel ends come together easily without tension. That's because the clamps were the right distance apart. Here's what happens if the clamps are too far apart. As you tighten the first half knot, things start to stretch. Don't go on tightening, or the stitch will cut right out of the tissue. Stop quickly and bring the clamps together. Then complete the knot. Now the knot is tied. Cut one end short and leave the other end long. This is going to be our stay stitch, and now is the time to set it in place on the stitch holder here. There's one best way to do this. Pick up this much spare thread and guide the thread over the middle of the stitch holder, under the lower post, across, under the upper post, and give it a little pull to set it in place. Once again, over the middle, under the underneath one, across, under the upper one, and give it a little pull. Once it's set in place, cut it, and there's your stay stitch, quite secure. To place the second stitch in just the right spot, 1/3 of the way round the circumference, calls for a little judgment. The best way to make this judgment is to present yourself, if only for a moment, with a clear view of the whole vessel circumference. To do that, you need to tip the vessel end up towards yourself so that you're looking down into it. And to do that, you need to use this useful maneuver. Using the needle as a temporary hook, pick up just a little adventitia way back here and lift up on it so the vessel end comes up. There, you can see the whole thing clearly, and you can see the obvious place for the stitch to go in. So now, put the tips of your forceps inside and pass the needle. Pull it through and pick it up again and get ready for your exit bite. You need to give this your very best attention because this is where your fair and even coaptation is determined once and for all, you must judge the position of the exit bite so that this length and this length are equal. To judge that, you must again present yourself with a clear view of the whole circumference of that vessel end by lifting it up and tilting it towards you. Now you can see where the right spot is. It's right there. So shoot your needle through and your second stitch is done. Here's why you need to see the whole circumference just for that vital moment. Vessels don't always hang with a perfect circular cross-section like this. If they did, you could look from above, put your second stitch in here, and be right every time. In reality, vessels often hang something like this, and if you decided to put your stitch in here, you'd be wrong by a long way. Going back to the action now, finish tying the second stitch and cut one end short, leaving the other end long. This is going to be your second stay stitch. Turn your magnification down until you can clearly see both the anastomosis and the second stitch holder that's down here. Now pull the thread down in this direction and get ready to fasten it to the stitch holder. Pull it under the underneath one and then pull up on it gently while watching the anastomotic side. As soon as you see it pulled tight like that, stop pulling on the thread, bring it across and fasten it in place. Cut it off and your second stitch is done. If you made your exit bite correctly, your two vessel edges will now be stretched out equally like this, and the rest of your stitching will be an orderly geometrical exercise. But if you made a wrong judgment at that vital moment, your front edges will end up grossly unequal, like this. This one's long and this one's short, and the rest of your stitching will be an untidy struggle ending up in failure. If you've misjudged it as badly as this, there's just one thing to do: cut it out and start over. Before we stitch up the front, let's take a look at the back of the vessel for a moment. See how the long, slack back edges hang nicely out of the way. Turning to the front side again, there's a little adjustment that's worth making. See how the two front edges are touching. That's not ideal. You can't really see in between them. Up till now you've had your clamps close together so as to make your first two stitches easy. Now separate the clamps a little bit till there's just a little gap between the edges. That lets you see what you're doing a whole lot better. Now let's put two stitches in here. For a reason I'll explain, it's best first to put them both in, then to tie them both. Put the forceps in the lumen, decide just where you want to go in, and pass the needle. Decide where you want to come out, put the tips of the forceps right there, and come on out. Pull the needle through, and the thread, cut it, and leave it. The next stitch is just the same. If the tips of your forceps are too big for the job, use the more slender vessel dilator instead. But remember, that's a delicate instrument, and don't use it for anything else. Now both stitches are in, it's time to tie them both. And that's the front done. Here's why you put both stitches in before you tie either of them. If you had tied that first stitch right away like this, you'd have closed up your nice wide open gap and given yourself a real tight spot to work in when placing your second stitch. In a space as confined as this, you hardly can see what you're doing. By contrast, with the previous stitch untied, you've got plenty of room, you can see just fine, and you can do a better job. Next, we're going to turn the vessel over and do the back side. But before getting into that, let's just digress and talk about one really tiresome problem, namely surface tension. You'll notice that your thread will often stick to itself or to nearby surfaces in the most aggravating fashion. This is a real hardship when you're trying to tie knots. You'll find the problem is worst when you have a medium quantity of water in the wound. There are two ways to go, therefore, if you want to get around the problem. One way is to take your irrigating syringe and flood the field completely, so you're tying your knot underwater. That's not hard to do. The other way is to take your sucker and remove all the surplus liquid from the wound. That works well too, but if you do that, don't go to the extreme of letting all the tissues get completely dried out, especially not the vessel itself. Now, let's get back to the action. Turn the clamp over and make sure it goes right over, so it's lying flat. Now, put the third stitch right in the middle of the long back edges. This, of course, is going to be the third stay stitch. Tie it and leave it long. Now, you're going to pull the third stay stitch first this way to stitch up this part, and then this way to stitch up this part and finish the job. It's a good idea to pull it this way first. Here's why. If you pulled it the other way and fix it to the near stitch holder, you'll find when it comes time to pull it the other way that you won't have enough thread to reach the far stitch holder. So, wrap it around the further stitch holder first, without disturbing the stitch that's already there. You're ready now to put in 2 stitches here. Now that we're on the back side, there's a particular danger of accidentally making a through stitch. That's a stitch which picks up the back wall. Just one through stitch will produce failure. So let me tell you how to avoid producing through stitches. I've told you already about the importance of accurately trimming the adventitia so that there aren't any loose tags of tissue that your needle can pick up and drag into the lumen. Apart from that, with every stitch you do, there are 3 important points you need to attend to in order to avoid picking up the back wall with your needle. The first thing is to keep the tip of the needle parallel with the vessel, not pointing downward toward the far wall like this. The second thing is to lift up on the wall that you're stitching, both going in and coming out, so that you bring the wall you're stitching away from the wall you're avoiding. There's a third important point which we'll come to in a moment. Right now you have to tie these 2 stitches, and then you have to change over the stay suture, and after that we'll return to the last important point. It's time to switch this stay stitch over. This stitch, which was our first stay stitch, has now done its job, so go ahead and cut it. Now, cut the third stay stitch loose from the holder up there, bring it down and hitch it to the near stitch holder. Now you're ready for the final stretch. Going back to the avoidance of through stitches, the third important point is to see just exactly what the tip of your needle is doing. Thinking you can see isn't good enough. Wishing you could see isn't good enough. Only seeing that you can see is good enough to give you the margin of safety that you'll need clinically in your microsurgical technique. Now everything's done. Cut the stay stitches, turn the clamp over, and take out the background material. Take your syringe of xylocaine and rinse the vessel with it. Leave that to act for a minute, and meantime, make sure that the fat pad is ready to be brought over into the wound. Once the xylocaine has had a minute to take effect, chase it out of the wound with plain Ringer's solution. If the xylocaine hangs around, it will prolong your bleeding time. Now you're ready to take off the clamps. This is going to bleed. Be ready to swing the fat pad over and be ready with some 4x4s to put on top of that. Take off the distal clamp. It bleeds a little. Take off the proximal clamp. It bleeds a lot. Put the fat pad over it, put the 4x4s over that, and apply gentle pressure with your fingers for 2 minutes by the clock. Then release the pressure and cautiously inspect the vessel. It's a bad idea to disturb a freshly anastomosed vessel during the first 10 minutes. It's likely to bleed if you touch it, and in any case, nothing you do is going to affect the outcome now, except perhaps for the worst. So, leave it alone. How do you tell if it's working? That's a very important question. You can generally tell just by looking. Here's what it'll look like if it's blocked. This movement is called longitudinal pulsation, and it's caused by the column of blood in the vessel hammering against a partial or complete obstruction. Here's what it'll look like if it's patent. No movement at the anastomotic site, but transverse pulsation, not very easy to see, distal to the anastomotic site, and quite distinct pulsation in the epigastric branch distally. If you can't make up your mind by looking at it, you need to apply a patency test. There are 2 patency tests. First, use the uplift test. Put your angulated forceps under the vessel distal to the anastomosis and lift up till you nearly occlude it. If you can see the column of blood alternately appearing and disappearing like this, the anastomosis is patent. If you're still in doubt, apply the empty and refill test. Even if you're not in doubt, learn to do this important test because it's the final test that you'll use in clinical practice. Use your straight and your angulated forceps. Occlude the vessel distal to the anastomosis with 1 pair of forceps, and with the other pair, empty the vessel gently in a distal direction. Make sure it's empty. Then release the proximal pair of forceps. If it refills, it's patent. If it doesn't, it isn't. The empty and refill test is only valid if you do it right. Both the emptying and the refilling must be done in the normal direction of flow. This is correct. This isn't. And neither is this. If you do the emptying or refilling backwards, you'll get false information. Remember, do the emptying and refilling in the normal direction of flow every time. Here's one other important point about the empty and refill test. If there's a thrombus at the anastomotic site, the last thing you want to do is to dislodge it by performing the test. That'll cause it to embolize downstream. So carry out the entire test, including the application of the first pair of forceps, well distal to the anastomosis. Last and above all, when you carry out this test, be honest with yourself. I know that's sometimes hard, but ultimately, your patient is going to thank you for it.
Welcome back to the Microsurgery Laboratory. In this videotape, we will be demonstrating the technique for rat femoral artery anastomosis using interrupted sutures. Here we have a demonstration of the model that we will be using. Now, your instructor will have taken care of the intraperitoneal anesthesia and will monitor the rat. We will be working on the femoral artery, and an incision will be made which runs perpendicular to the vessels. The legs are shaved in preparation for the dissection. Just to give you an overview of what you will be working on, this is a rat that has already been dissected. The common femoral artery here lies between the nerve and the vein, and it runs beneath the inguinal ligament and runs down the leg this way. It gives off the epigastric vessels, which run to the fat pad, and we will be seeing all this in a lot more detail in just a second when we begin the actual dissection. We begin with our incision. Notice that we're working on the right leg, which is easier to work on than the left leg if you happen to be right-handed. So we usually start with the right leg. And we make the incision just through skin, pull the skin tightly apart, and come down. We don't want to go too deeply, just down to the level of the fat, and then we pull the skin apart to do some blunt dissection. The next step is to mobilize the fat pad, and we will be doing this using the microscope. So from now on in, we will be looking through the microscope with the camera. Now we are looking through the microscope under low power magnification. The tools that you will be using for this portion of the dissection are a regular Adson forceps and a small Metzenbaum scissors. We use these instruments until we have exposed the fat pad. Now this is the fat pad, and our job at this point is to mobilize this so it's free of the underlying tissue. We do like to save the fat pad because it comes in handy after the clamps have been removed when the vessel has been repaired. Coming around in a counterclockwise fashion to free it up to here, and again in a clockwise fashion around here. Now you'll notice that underneath you can see the vessels emerging, and this is the epigastric vessel that goes up into the fat pad, and we'll just finish freeing it up over here. You do normally have some bleeding from the fat pad when you do this maneuver. Now the fat pad has been freed up, and your vessels that you'll be working on are down in this area here. If you do encounter a bleeder from this area, you can use the bipolar electrocautery. But be careful when you elevate the fat pad not to come across this large epigastric vessel, and don't go too deep, because then you'll come through the femoral vessels themselves. Blunt dissection of the fat pad can be done using Q-tips, and now the fat pad has been completely mobilized. Now it's important to keep the fat pad moist using a moist white gauze, and we wrap it up, and this holds it off to the side and not only keeps it moist but also helps to keep a little tension on it, which helps to better expose the vessels. Your next job is to mobilize these muscles and to view the inguinal ligament so that we can see the vessels better. Let's do that now. The way we mobilize the proximal muscles here is just using Q-tips, and we just gently wipe over the vessels and the surrounding tissue, and you can see how easily this comes into view. Here is your inguinal ligament, and this is the proximal margin of your dissection. Now we are going to want to put a retention clamp in the muscles to provide some countertraction so that our field will stay exposed. Let's do that now. Here we have some bent retractors that your microsurgical instructor will provide you, and this goes in the muscles, and we secure it with a rubber band and a push pin on the other side of our stage. Up until this point, you have been using the macro instruments. It is time to put these away and take the micro instruments, because the remainder of the dissection is done using the microsurgical instruments. Okay, now we are under higher power magnification, and I have two jeweler's forceps in my hands. This is our quarry. In the middle, we see the pulsating femoral artery. This is the large but thin-walled vein that bleeds quite easily if you happen to jab it. And here in the loose connective tissue is the femoral nerve running next to the artery. Our next job is to separate the artery from this connective tissue, and this can be done in a number of ways. Probably the least harmful and dangerous way is just to do it with blunt dissection, and we will demonstrate this now. Other techniques involve using curved but blunt scissors to dissect out the perivascular tissue. Let's see how we do this bluntly. We pick up the connective tissue on top of the vessel, being careful not to pick up the vessel itself, and we gently make a window here by alternately pulling one side to the other, and here we have the vessel exposed. Now we can follow this plane further down, and if you would like, you can augment your dissection technique using a Q-tip. Let's see how a Q-tip works. We take the Q-tip, we can just gently push this loose connective tissue, and here we see the femoral nerve coming into view quite nicely. And this exposes the artery very easily. Now we have dissected off the far side of the vessel first. The next job is to dissect the tissue between the artery and the vein. Notice when we pick up the artery, we only pick it up by the adventitia. We never want to pick it up with the full thickness of the vessel, such as this, which I will not do, because this causes significant trauma to the vessel and can predispose to a later thrombus. So we only use the adventitia as a hook to manipulate the artery. Now, when dissecting the artery away from the vein, there are a number of ways to do this. One neat trick is just to establish a little window with your forceps, then to do what's called hydrodilation, which is to take a catheter with saline. This is hydrodilation or hydrodissection technique, and we introduce it into the perivascular sheath, and we distend it, and you can see how this very nicely shows the plane of dissection between the artery and the vein. Now, we can either complete this plane of dissection using forceps, or we can use blunt dissecting scissors. Let's see how it works with the dissecting scissors. Now, these are curved dissecting scissors which are blunt. You see the tips are blunt. The adventitial scissors have a sharp edge. But here we will use the blunt dissecting scissors, and you want to be careful that you can see the tips at all time and that you do not inadvertently cut a deep branch of the artery or the vein. Notice this is the large branch that comes off the artery called Murphy's branch, which is usually present, and if you don't see the tips of the scissors, you might accidentally cut it, causing a significant amount of bleeding. Now, this little oozing here is from the vasa vasorum, which run along with the vessels, and this is usually seen. So now we have freed up the artery, and in fact there's another little arterial branch here at the top as well. Now we need to deal with this so-called Murphy's branch, and what we're going to do is to tie it off and to bipolar the other end. Let's show how that works now. Let's show how we ligate Murphy's branch now. I'm holding a curved needle holder in my right hand, and we pass a 10-0 suture underneath the vessel. We grab it on the other side and retrieve it, and now we will tie it. Now, it's helpful if your instructor holds the artery up in the air for you so that you can tie this off. Let's get the end of the suture away from the vessel, and we're going to tie it close to the artery. And those are 3 square throws. Now we remove the excess thread and dispose of it so it doesn't stay in your field like this and obscure your vision, and you can confuse it with the ends of the sutures that you actually want to tie. Then normally we bipolar the end of the artery away from the vessel in this way, and then we can cut it, and we're finished with Murphy's branch. If the vessel goes into spasm from your handling, you can use some concentrated xylocaine solution in order to try to break the spasm, and we'll do this now. Now this particular specimen has a second Murphy's branch, which is quite small, and you can see it coming off the top where it bifurcates into two. This one we're just going to bipolar, and we're not going to tie. It's quite small. The important thing, though, if you're doing this, is not to bipolar too close to the main artery, because you might damage the vessel. Let's dry off the field a little bit. And we can then bipolar this vessel. And cut it. And now we have the vessel freed up from close to the inguinal ligament all the way down to near the takeoff of the epigastrix. This amount of free artery will allow you to do the anastomosis very easily. The next step is to put the background material in. The purpose of the background material is to separate the vessel from the remaining tissue so that you can see it nicely. The only key point about the background material is not to force it. If you haven't freed up enough vessel, you may tear the little vessels coming from the artery on either side. It should slide nice and easily beneath the vessel. If it doesn't, either you need to cut the background material or free up more vessel on either side. Now let's apply the vascular clamp. For the purposes of our model, we use a double vessel clamp, such as this, which has a stage for tying retention sutures. In actual clinical practice, we will frequently use a double clamp without the stage because the assistant can hold the sutures. But for the purpose of our training lesson, we will use this because it enables you to do the dissection all by yourself. Now, gentle pressure allows the clamp to open up, and here we want to introduce the clamp proximally, and for the distal clamp, before we put the vessel in, we want to pull a little bit of tissue in between to take the traction off the vessels. Now it's important to note where Murphy's branch has arisen in between the clamps, and in this case it's right here, right in the middle. That's important because you don't want to have Murphy's branch right in your suture tying way, so we can excise Murphy's branch, which we will do for this particular vessel. Now the reason to pull the vessel in is so that there's not that much tension on the vessel, because if you excise Murphy's branch, you won't have enough vessel to get back together again then. Now we're ready to cut the vessel. For this we use a straight, sharp, adventitious scissors and the same forceps that we've been using. Now, because the Murphy's branch ended up right in the middle of our vessel, we are going to want to excise that. So we're going to make two straight cuts. One on one side of Murphy's, right here, and the other on the other side of Murphy's. After excising Murphy's branch, there may be excessive tension on the vessel, and this is easily removed by placing a single vessel clamp on one end of the artery, opening up one of the double vessel clamps, and then pulling the artery to the inside of the clamps. This will eliminate the excessive tension on the artery caused by the removal of the Murphy's branch portion of the artery. The vessel is then irrigated with heparinized saline. Let's look at an artery that does not have a Murphy's branch in the area where we will cut it. Now we're ready to cut the vessels. We're going to use the straight adventitial scissors to make a straight cut, and we are going to then immediately irrigate the blood out of the lumen to avoid thrombus formation. So we place the sharp scissors in the center of the vessel. We'll make the cut. And we'll take the heparinized saline and we spray it in the lumen of both vessels to irrigate out any blood that remains in the lumen. Want it to be nice and clean to avoid thrombus formation. This is adventitia, and if it is not cleaned off the ends of the vessel, it can flip into the lumen and cause a thrombus. Now, in order to do this, first, we put some water in the field, or some saline. Let's do that now. And this allows the adventitia not to be quite so stuck down. Then we pull on the adventitia, creating a little bit of a cuff off the end, and we take the adventitial scissors, which are nice and sharp. We want to cut the adventitia. Now, when you do this, you don't want to cut at an angle, which will create a divot in the vessel. You want to cut just parallel to the tip. Let's zoom in a little more and look at this under some higher power magnification. You keep pulling the adventitia away like this, and that will allow you to clean off the vessel end nicely. On this side, again, you pull it so that the adventitial covering comes off the end of the vessel, and again you want to come in parallel to the vessel end and gently resect the adventitia. The major mistake in doing this is to accidentally cut the vessel, and if that occurs, you will then need to cut back on the vessel to get a fresh end. Now you see here is a small clot that is formed in the lumen, and this needs to be irrigated out using saline, like that, heparinized saline. The adventitia has been trimmed. There's one more step before you begin the process of suturing, and that is dilation of the vessels. Dilation serves two functions. One, it expands the vessel size to make it easier to put stitches in, and second, it paralyzes the smooth muscles. Now we insert the ends of a vessel dilator, which is a long, thin, blunt-ended instrument, and we dilate the vessel about 1.5 to 2 sizes. Look how nicely that dilates. Now we switch hands, and we put the vessel dilator in our right hand. We lift up the opposite. See, there's a little clot in there that we'll have to irrigate out, and we again dilate it about 1.5 to 2 times. Now we will take you step by step through the arterial repair technique. First, we want to find the interior of the artery on the right-hand side. This is done by placing the tips of the jeweler's forceps in the interior and gently opening them. If you do this so that the tips are parallel to the clamp, this will allow you to visualize the exact ends of the artery, that is the 12 and the 6 o'clock position. You will be placing your first suture into the 12 o'clock position, that is 180 degrees away from you. This is placed and should be done so that the tip of the needle enters the lumen 90 degrees or perpendicular to the vessel wall, so that you spear all 3 levels of the artery. This is then passed to the left-hand side of the artery and placed through. We then tie, once this is done, the short end of the suture is cut. The long end of the suture is then placed between the ends of the goalpost. It is then brought underneath the left-hand goalpost and across and again underneath the right-hand side of the goalpost, that is making a figure of 8, and this will lock the suture in place. The end is then cut. Now attention is then turned to the opposite end of the vessel, that is closest to you, or the 6 o'clock position, and a suture is then placed in the same manner in this exact location. This will bisect the artery. Once this is done, that long suture is wrapped around its own goalposts and this will then suspend the vessel between the two stay sutures. At this point, we search for the mid portion between these two stay sutures, and this will be the location for the third suture. This is placed by visualizing the lumen and then placing it through the right-hand side and then the left-hand side of the vessel in the same manner. This is then tied, and one end is cut short and one end is left longer so that the vessel can be pulled up and down to expose the interval between the three sutures. First, the stay suture is pulled toward us, and a suture is placed in the mid portion between the first stay suture and the middle suture, and this should bisect it. If this is done properly, only one suture may be necessary in this location. This suture is then tied and cut, and the middle stay suture is then pulled away from you, and a fourth suture is placed between the middle suture and the other stay suture. Once this is done, the clamp is then flipped, and a middle suture is placed between the stay sutures on the far side of the repair. And again, the stay suture in the middle is left long, and this can then be pulled top and bottom so that an additional suture can be placed in between the middle and the stay sutures. Once this is completed, you have to inspect the repair and make sure that there are no large gaps. If there are, additional sutures may need to be placed. Now, we are ready to begin suturing. First thing we want to do is bring the ends of the clamp a little bit closer together, which is done quite simply like this, so that the vessel ends come into approximation quite nicely. Now you're ready to place your first stitch. We are using 10-0 suture. Notice that I am using a curved needle holder, grasping the needle about 2/3 of the way back from the tip. Now it's hard to pick up the vessel and to see, so what we do is we use a little trick. We use the needle itself to hook the adventitia and just lift it up in the air so we can see the vessel lumen. Then we insert the jeweler's forceps in the lumen, and by spreading it in this direction, it shows us exactly where we need to go, which is right here, about 2 needle diameters back from the edge. So we push it through, and we push it through as far as we can, and we pick it up again using the needle holder, and we follow the curve gently through so we don't apply excessive force on the vessel. Then we reposition our needle again, and we're going to pick up the other vessel. Now it's very bad to pick up a vessel like you would pick up skin. I won't do it, but to pick it up like this and crush it like that, that damages the vessel. So you never want to do that. You just want to hold it by the adventitia or put one of the ends of your forceps inside. Now on this side you can see exactly where you want to go, which is opposite that first side, which is right here. We'll put that through, and again we'll gently bring it through using our needle holder. Now we want to switch hands, and we're going to pull in a straight line. I'm going to zoom out at this point so we can see where our end of the suture is, and once that comes into view, you want to let it stop. Now we can bring the needle back somewhere where we can find it, over here, and here is our end of the suture. We're going to zoom in a little bit. Because I'm using a needle holder in my right hand, I'm going to tie using the forceps in my left hand. I'm going to pull so there's a little bit less suture protruding, and we're going to pick this up using my palm facing up with the right hand. We're going to wrap this around. I normally do a surgeon's knot, which is 2 loops. So we go 1, 2, and then we pick up, and this will come down as a nice square throw like this. Don't want to make it too tight. Then we do the second one, which is a simple throw, and we cross our hands and bring that one down, and finally the third and we tighten that up like that. Now we cut this end short and we dispose of it so it doesn't stay in the field. Now we take advantage of the suture holding clamp application feature of our double clamp. We pass the suture through the two goalposts and then around one end and around the other end. And then we cut this end short. This will allow the first stay suture to be anchored to one end of the clamp. We then pass a suture 180 degrees apart from the first suture. This will be our second stay suture. This is placed in the same manner, and it is then tied. This is our second throw. And finally, the third throw. Notice that these are all square throws. We then take the long end of this suture and wrap it around the stage holding area on the opposite side of the first suture. And this is done in a similar manner. The third suture is placed midway between the first and second sutures. Notice that the bites are equidistant and that we did visualize the interior of the lumen when placing the suture. Here we use a surgeon's knot. This is a rather short end of the suture, and in your practice you will probably be using a longer segment of suture. Here we are putting the second and the third suture throws. Now this middle suture can be used as a traction suture to allow us access to the interval between the three sutures. So we leave one end longer. In this way, either your assistant can pull it top and bottom, or you can hold it with your left hand and insert the needle with your right hand. Here we are. Under high power, we can actually visualize the interior of the lumen, and we pass the suture midway between the middle suture and the suture that is closest to us. It is helpful if you have an assistant. The assistant can pull the long end of the middle suture out of the way. This is a very short suture, and as stated before, you will probably have a longer length in your laboratory practice. But here we are demonstrating suture conservation principles. Both of the ends of this suture are cut short. We then pull the middle suture tail towards us, and we put the final suture on the wall closest to us, midway between the first and the second sutures. Note that it is helpful, if there is any question whether or not you have engaged the back wall with your suture, to flip the clamp, and you can see the needle or the suture clearly visible and not engaging the back wall. This is a very helpful check to use if you are uncertain whether or not the suture or the needle have snared the back wall. The suture is tied using a surgeon's knot on the first throw. That is a double loop. The second throw, squared, and finally the third throw. Both ends of this suture are then cut short. Now we gently flip the clamp, and this is why it is important to have enough artery freed up on either side so there is no tethering. Here we are placing the first suture on the opposite side, again, midway between the two stay sutures. We will repeat the identical process here. Our stay suture in the middle now is pulled away from us, and we are placing one equidistant. And here it is pulled down, and we are placing one equidistant between the far and the middle sutures. Notice that you can actually see the tip of the needle under high power and clearly visualize that you are not engaging the back wall. If there is any question at all, the tips of the jeweler's forceps should be inserted into the lumen so that you can clearly visualize the intima and make sure that you are not engaging the back wall. Here we are tying the final suture. We then flip the clamp back over and we cut these stay sutures. Your instructor will later clean out the remnants of the stay suture from the clamp. We investigate the anastomosis and we see that there are no gaps. We now remove the distal end of the clamp, the low flow side, so there is not excessive bleeding. Then when we have control of the clamp, we remove the proximal end. There is always bleeding through the anastomosis when the clamp is removed. We remove the background material, and now we will remove the proximal clamp. Here the fat pad is placed on top of the anastomosis to provide hemostasis, and a gauze sponge is placed on top. Here we are showing the uplift test. This will show the patency of the anastomosis. Distally, you can see the pulsating arterial column as we gently lift up on the vessel. This is the empty refill test, gently grasping and emptying, and you can see the refill. We have an adjunct in our laboratory to assess the patency. In addition to the visual and the refill test, we can use a Doppler probe to assess by sound waves and a visual input on the patency of the vessel. Let's listen. Ah, the sound of success. The following are important points to remember concerning suturing technique. First, the correct position of the needle. You should position your needle so that the needle is held in the needle holder approximately 1/3 of the distance from the insertion of the suture material to the needle. You should maintain the needle at a 90-degree angle as you approach the vessel wall so you do not take an oblique pass through the vessel wall. Proper insertion at a 90-degree angle allows the vessel to be properly everted. Finally, you should always keep the point of your needle pointing upwards in order to avoid grabbing the back wall of the lumen when you are placing your suture. The second important point is correct suture positioning. You should try to place your stay sutures exactly 180 degrees away from each other in the corners. This will help to avoid bleeding, which typically occurs at the edges of the anastomosis. Secondly, you should try to position your third stitch directly in between the two stay sutures. You can use the center middle suture to gently pull the artery side to side so that you can place the intervening sutures on that wall. Finally, you should try to take small and equal bites in the vessel wall to avoid leaving gaps through which bleeding can occur. Third, avoiding the back wall is essential. Remember to keep the tips of your straight jeweler's forceps inside the lumen to separate the walls, which will allow you a nice view of the interior of the lumen. You can maneuver your needle inside the vessel lumen under high power magnification to make sure that you see that it is only going through one wall of the vessel and not catching the back wall. Now, rat arteries are somewhat different from human arteries And in human vessels, particularly when there is atherosclerosis, the intima can be quite different from the rat and often delaminates from the media. In this case, it is essential to visualize the intima, and usually the jeweler's forceps need to be inserted to open up the inside of the lumen so that you can make sure that you are engaging all 3 layers of the vessel. On behalf of the Microsurgery Lab here at Columbia, I'd like to thank you for watching this videotape. And Yelena and I wish you the best of success in your microsurgical pursuits.
Good luck.
Welcome to the Microsurgery Laboratory here in the Department of Orthopedic Surgery at Columbia Presbyterian Medical Center. I'm Dr. Robert Strouch, and today we are presenting a video on the technique of one-way up suturing of vessels. This is a useful technique when the vessel cannot be turned towards the opposite side in the normal manner. I hope you find this video useful. Mastery of the one-way up technique is invaluable in clinical microsurgery. The one-way up technique is necessary when the vessel cannot be flipped over to sew the back wall. This may occur in situations where the vessel ends are shortened by trauma, tethered by local vascular branches, or where the clamp cannot be flipped due to local anatomical obstructions. In these cases, the one-way up technique allows the vessel to be completely sutured without flipping the clamp over. This tape assumes a familiarity with the conventional techniques involved in preparing and suturing arterial anastomoses in the rat common femoral artery. In this tape, we will first describe step by step the technique for interrupted one-way up suturing of an end-to-end arterial anastomosis. At the end of the tape, we will go over the key points we feel are important for successful one-way up suturing technique. To simulate a scenario with tethered vessel ends, we will use the arterial segment between the so-called Murphy's branch proximally and the epigastric artery distally, although any portion of the vessel may be used. After cleanly dissecting out this segment, apply the vessel clamp with the tips facing toward you. This step is essential. If the tips are pointed away from you, the body of the clamp may interfere with your access to the vessel. Divide the vessel between the clamps and prepare the ends in the usual manner. Place your first and only stay suture 180 degrees away from you. Getting this stitch as far away from you as possible is another key step. Place this stitch in the usual manner, sewing from right to left, outside in on the right side, and inside out on the left side. After tying the knot, secure the long end to the vessel clamp and cut the other end short. Now keep in mind that only the back wall will be sutured one way up. You should see the back wall nicely exposed. Now for the first suture in the back wall. It is usually easier to place the first suture pass in the left side vessel wall from outside in, than the second pass in the right vessel wall from inside out, as seen here. There are 2 ways to hold the needle for the first pass. First, you could hold the needle in the standard forehand manner. Although this technique may seem more familiar, depending on the orientation of the vessel, you may need to shift your hands and body into an uncomfortable angle with the forehand technique. This is especially true if the vessel is perpendicular to your body. As an alternative, holding the needle backhanded, as seen here to place the first suture, may be technically easier in that you do not need to shift your hands as much. We will use the backhand technique here. Grasp the needle backhanded and pull the left side of the vessel wall to the left, exposing the under surface. Hold the vessel by the adventitia. Make your first pass from outside in, taking care that once completely through, the tail of the suture faces you in order to avoid entangling the suture. Next, pass the needle forehand from inside out of the right vessel end, grasping the adventitia on the vessel corner for support. The key at this point is to bring the needle tip out on the near side of the stitch to avoid entangling the suture. Tie the suture in place and cut the ends, the knot now resting on the undersurface of the vessel. Use caution not to cut the vessel. Proper placement of the first stitch in the back wall is crucial in that you should try to place it as close to the stay suture as possible. No matter how closely you put it to the stay suture, it's rarely as close as it seems. Keep in mind that the gap between this suture and the stay suture is a common site for leakage once the clamps are removed. Now continue suturing the back wall in the same fashion. Here we see the second suture being placed, tied, and cut. Now the third suture is placed, tied, and cut. Once you reach the midpoint closest to you, which is 180 degrees away from your stay suture, you can now proceed with sewing in the normal single-pass forehand manner, that is, from right to left. We recommend that the final two sutures not be tied until after they have both been placed, in order to avoid catching the back wall. You can then release the stay suture and remove the clamp. The fat pad is applied in the usual manner for hemostasis. At the conclusion of the anastomosis, we now see excellent blood flow, proximal and distal to the anastomosis. To review, the four important points to remember for successful one-way up suturing technique are: Number 1, start with the clamp tips facing toward you. Number 2, place your first stay suture 180 degrees away from you. Number 3, sew the left side of the back wall of the vessel first and decide if a forehand or backhanded loading of the needle is more comfortable for the vessel position. 4, place the first back wall stitch as close to the stay suture as possible. With these helpful tips in mind, the one-way up suturing technique should provide a useful addition to your microsurgical repertoire. We hope you have enjoyed watching this instructional tape, and good luck with your microsurgical practice. This tape was made possible by an educational grant from the Accurate Surgical and Scientific Instrument Corporation. The Microsurgery Laboratory in the Department of Orthopedic Surgery at the Columbia Presbyterian Medical Center offers both a basic and advanced course in microsurgical training. Contact Yelena Akalina at 212-305-0992 for registration details.
This videotape offers a demonstration of several microvascular techniques, beginning with a vein anastomosis. These demonstrations are a continuation of the first videotape on basic techniques. The vein presents a thinner vessel wall than the artery, and several modifications to the technique of arterial anastomosis are useful for achieving a successful outcome. The dissected rat femoral vein is clamped standardly, taking care not to include the cauterized muscular branch of the vein within the jaws of the temporary occlusion clamp. The vessel is transected in the mid-portion, but away from the vein branch site, using a single continuous transection with microscissors. The lumen is irrigated with a standard anticoagulant, here using heparin at a concentration of 20 units per milliliter. The cannula may be brought into the lumen without causing intimal damage. As a review of the pattern for stitch placement, the cross-sectional diameter of the vessel is considered in schematic form, with the top surface of the screen representing the top surface of the surgical field. The technique that will be presented is the halfway estimation technique, which involves sequential placement of stitches at the halfway points along the circumference of the vessel wall. The first two stitches are placed on the sides, 180 degrees apart. The third stitch goes on top at a point 90 degrees from the side stitches. The fourth and fifth sutures go on either side, halfway between the third stitch and the first two. At this point, the entire front wall is complete. The clamps are rotated, which provides the microsurgeon with direct access to the previous back wall. At this point, the sixth stitch can be placed at the topmost point, 90 degrees from the first two stitches. The seventh and eighth stitches go in on either side of the sixth stitch. The end result is a very symmetric placement of 8 stitches in a 1 millimeter vessel. Returning to the vein, the suture is brought to the field and grasped firmly in the needle driving instrument. Here a Look 10-0 nylon microsurgery suture on a cutting taper needle is being used. A jeweler's forceps can be used for driving the needle, as is shown in this vein repair. The tip of the jeweler's forceps in the non-dominant hand are placed inside the vein lumen, and a point on the side of the vein is identified for the first needle pass. Here the pass occurs very close to the muscular branch that was previously cauterized. The needle is passed entirely through the wall, re-grasped, and a point on the other vessel end is identified that corresponds to the first side. The needle is positioned in the lumen on the point of exit and The next technique that will be demonstrated is the end-to-side anastomosis. This procedure is performed clinically in a variety of connections, most often in free flap transfer, artery to artery, vein to vein, or artery to vein. The rat femoral vessels provide a good model for general practice of this procedure. The artery end can be anastomosed to the side of the vein, or alternatively, the end of the vein may be hooked into the side of the artery. In this demonstration, the artery will be anastomosed into the side of the vein. A good spot on the vein should be identified beforehand to facilitate the ease of the approach. The distal point on the artery will be brought into the topmost aspect of the vein. To achieve this, the artery is ligated distally and clamped proximally. It is then transected near the distal ligation. As always, blood is irrigated from the lumen, and the adventitia is trimmed from the end of the artery. An approximating clamp is applied to the vein in preparation for the venotomy. The general approach to the anastomosis is considered here in schematic representation. A venotomy is made on the topmost aspect of the vein. The artery is then brought into location. The first stitch is placed closest to the origin of the artery at the longitudinal extreme of the elliptical venotomy. The second stitch is placed 180 degrees opposite the first stitch. Subsequent stitches can be placed in any order, using as many stitches as are considered necessary. In making the venotomy, there are several approaches. Here, the adventitia is grasped with the forceps using slight retraction, and the microscissors make a single cut into the vein, making sure not to go too deep. The lumen is promptly irrigated to avoid blood clotting and to allow better visualization of the entrance hole. The instruments are then reversed in the hands, grasping the microscissors in the opposite hand. The jeweler's forceps grasp the dog ear created by the first incision, and the microscissors cut out a portion of the vessel not more than 50% greater than the estimated diameter of the artery. The venotomy is inspected to be assured that there are no ragged edges and that the size is appropriate. In placing the first stitch, one can begin on the arterial side. The needle is driven from the outside to the inside at a point that should minimize twisting of the artery. The needle is placed inside the venotomy to allow the needle to go from the inside of the vein to the outside. At this point, extra caution should be exercised to make sure that the knot, when tied, does not twist any of the vessel components inappropriately. Here, the suture is passed underneath the artery to allow correct orientation for knot tying. The second stitch is placed 180 degrees opposite the first at the corresponding longitudinal extreme of the venotomy. The forceps may be advanced into the lumen of the vein and used as a counterpressor for needle placement. The needle is placed through the artery at a corresponding point, placing the needle through the wall approximately 2 wall thicknesses from the edge. Knot tying proceeds standardly. The dimensions of these vessels suggest an 8-stitch repair. Therefore, side stitches may be placed at the 90-degree points between the first 2 stitches on either side. The approach may be made easier if the arterial clamps are rotated. When possible, the forceps may be brought inside the lumen of either vessel to allow more accurate placement of the needle. With the 3rd stitch in, progression to the 4th and 5th stitches on the same side of the anastomosis may proceed. In this example, a relatively blind approach to driving the needle was performed, which has resulted in a partial back wall stitch. This is revealed by inspection facilitated with the irrigation cannula. The difficulty in placing the cannula in the lumen illustrates the presence of the error. The needle is therefore withdrawn and another attempt is made. By grasping the adventitia of the artery and retracting downward, the vein wall falls away more easily, providing better exposure. The needle can be advanced into the vein, then the tip of the needle can be moved inside the artery to assure that the back wall is free. The 5th stitch is placed similarly. In this situation, the dominant hand driving the needle must be rotated around the microsurgical field so that advancement of the needle can be done perpendicular to the suture line. This shifting of the hands is necessary since the suture line changes with the circumference of the anastomosis in an end-to-side anastomosis. Here, careful inspection of the lumen is done on both the arterial and the venous sides using the irrigation cannula. This assures that an error has not been committed during needle placement. The knot is tied, completing 5 of the 8 planned stitches. The 6th stitch is placed midway between the 2 longitudinal stitches, here driving through the artery first and then on to the vein. Because of the difficulty in approach and working without an assistant, the maneuvers are made without using the forceps inside the lumen. A good result can be achieved with experience. In this approach to the 7th stitch, the suture line presents the most awkward angle for the anastomosis. The surgeon can rotate the needle-driving hand around the field even more, or the hand may be brought back in an even more awkward position. An alternative, and often the easiest approach in this situation, is to grasp the needle in a backhand orientation, which requires the development of technical versatility in the approach to needle placement. The 8th stitch is placed, completing the anastomosis. Sutures are now trimmed, and any final inspection may be done at this time. In considering the order of clamp release, the lowest pressure end should be released first, working toward the high pressure end of the revascularization. Thus, both vein clamps are removed first. Darker venous blood is seen within the vein, with moderate retrograde flow into the artery. Upon release of the arterial clamp, the vein immediately becomes distended with oxygenated blood. This design of end-to-side anastomosis allows a unique method for evaluating patency. The inflow artery can be occluded temporarily with the jeweler's forceps, and this allows venous blood to return within the vein. Upon release of the forceps, arterial blood returns to the entire system. The techniques demonstrated in this presentation represent the basic techniques required for clinical microvascular surgery. Proper training and adequate practice are essential components of good microsurgical technique. Detailed information of the skills demonstrated in these videotapes are given in the companion laboratory manual.
A vein graft is something you must be ready and willing and able to do at a very early point in your microsurgical training. Even the simplest trauma situation where a vessel repair is called for will require a vein graft more often than not. A lot of time is wasted and a lot of harm done in the mistaken attempt to pull damaged vessel ends together under tension in the effort to avoid what's referred to as spending the extra time in doing a vein graft. The only time that's wasted with vein grafts is the time that you spend screwing around pretending you're not going to need one. Let's look ahead now and see what we're going to be doing in this exercise. You're going to expose the femoral artery and the epigastric vein. You're going to make a defect in the artery. Then you're going to take a length of epigastric vein and use it to bridge the defect with 2 end-to-end anastomoses. As you can see, you're going to need to fit a lot of clamps into one tiny wound, and there's only just room for them all. You need to take trouble right at the outset to give yourself the widest possible exposure, otherwise you'll be badly crowded later on. Start out by making a bigger incision than usual, all the way from here to here. Take extra trouble to dissect the fat pad completely free. While doing so, take care of the epigastric vessels. That vein is going to be our graft. Go on mobilizing the fat pad until you can hang it right out of the wound. The weight of the fat pad, pulling on the epigastric vessels, puts a little tension on them. This makes the vein much easier to dissect out. We'll come to that dissection in just a minute. Next, dissect out the femoral artery and go much further proximally and distally than you usually would. Proximally, retract the inguinal ligament and free up the vessel right up under the ligament. That's far enough. Distally, go right down to the epigastric origin, dividing this branch if you need to. Make sure you get the vessel free and clear all the way down. Now turn your attention to the epigastric vein. You need to dissect it free all the way from here, where it enters the femoral, to here, where its first big branch from the fat pad comes in. Do the dissection in a systematic way, remembering to use round-pointed dissecting scissors. After clearing away the loose overlying tissue, identify the vascular sheath and make a small window in it. It's quite a distinct layer, and it's essential to get inside it. Having got inside it, divide the vascular sheath from one end to the other, using the tip of the scissors alternately to probe and cut, probing ahead each time to separate the sheath so that when you cut it, the sheath already stands clear of the vein. Now the sheath is lying open, free up the far side of it. Hold on to the edge of the sheath here where the vasa vasorum are and stretch it out to the side. Dissect down along the fibrous partition which separates the vein from the artery. That partition is part of the vascular sheath of the vein. You don't want to take any of that sheath with your vein graft. Now you've done the far side, clear the near side of the vein in the same way by laying hold of the vascular sheath and dissecting in similar fashion. Finally, get beneath the vein, lift up on it, and divide any fibers which are still holding it. Now the whole vein is free from end to end. Raising the vein graft that way is certainly tedious, but it isn't nearly as tedious as what happens if you don't do it that way. If you take the trouble to dissect the vein graft out in the right tissue plane, what you get is this: a nice clean vessel as your graft. If you dissect it out crudely, without attention to the proper tissue plane, you'll end up with a severely punished piece of tissue like this, all covered in perivascular tissue and impossible to deal with. With the vein fully prepared, it's time to clamp the artery and cut out a piece of it. Take 2 small clamps and put them on, one as high as possible, right up under the inguinal ligament, and one as low as possible, right down by the epigastric. Now, make the arterial defect. It's important to cut out just a small length from the middle of the artery, so that you still have 2 good long vessel ends to work on. These vessel ends may look really long, but in fact they're only just long enough. When you do the anastomoses, you're going to have another clamp here, and you're going to need enough vessel here to work on and enough free vessel here to be able to turn the clamp over without hurting the vessel. If you make the mistake of cutting out too much, your vessel ends will be too short and you'll end up with this situation. No vessel end to work on and no free vessel here to let you turn this clamp over relative to this one. Take a ruler and measure the arterial defect. Here it's 8 millimeters. That's how long the vein graft needs to be. When we talk about 8 millimeters of vein graft, we mean 8 millimeters measured when the vein is still intact and in situ and under its normal resting longitudinal tension. We don't mean 8 millimeters of vein that's been excised and that has collapsed down to half its normal length. If you measure off the vein under those conditions and use it as a graft, as soon as it gets arterial pressure back inside it, it'll jump right up to twice the length you thought it was, giving you this effect: a redundant graft with a severe risk of kinking. Going to the vein, take the ruler and mark off the 2 points on the vein where you're going to cut it. A couple of bipolar burns on the nearby tissue will serve as markers. Now, ligate the vein above and below the points that you've marked. Cut through the vein at one end and empty the blood out. Then cut the other end. Now that you have the vein graft loose in the wound, be extremely careful not to lose it. A careless dab of the sponge or a moment's contact with the sucker can leave your wound looking distressingly empty. If you need to park your vein graft somewhere, park it here while you go and take a break. Now you're ready to do the anastomoses. By now, I assume, you can do straightforward end-to-end anastomoses quite easily, both in arteries and in veins. If so, you'll find nothing unfamiliar about these anastomoses. You can use beginner's technique if you wish, as shown on the basic artery and vein tapes. Or you may feel that you're ready for something a little more advanced, in which case you can use one or other of the techniques that are shown on this tape. The first is a 2 stay-stitch technique, but done without the wire suture holding frame. The second is the no turnover or one-way up technique, which is described in full on another tape. Just before getting to the anastomoses, there's 2 small matters to address: how to dilate that very tiny vein, and which anastomosis to do first. The problem with dilating the vein is that you can't get both tips of the vessel dilator in. They're too big. So use just one of them at first. Once you've got one in and given a little stretch, you can get the other one in and give it a real stretch. The secret of success is to have a firm grasp of the vessel end with the other forceps while you're doing this. Now, which anastomosis first? If you're right-handed, it's best to do the right one first. Here's why. On the first anastomosis, the double clamp is free to move around all over the place because the vein graft is hanging loose in the wound. If you do the left-hand anastomosis first, the double clamp will run away from you every time you go to put a stitch in because there's nothing here to pull against you as you pass the needle. If you do the right-hand anastomosis first, the tension from the artery keeps the double clamp from running away as you pass the needle, and you have a whole lot more control. Okay, let's now get on with this first anastomosis. This plain approximator clamp without the suture holding frame will do the job quite nicely. To hold the stay sutures, cut a piece of background material with slits in each end, like this. Put the stay stitches in at 120 degrees, keeping them both equally long. Don't cut this one short. You'll need it to be long when you turn the vessel over. When you've done the near side, unhitch the stays and switch them over. On the back side, see how you can get along without using a third stay suture. The vessel edges are rather loose, but you can bring them under control by tightening the tissue, either by pulling on the vessel edge, which works well on the first few stitches, or by pulling on the previous suture, which works well for the last few stitches. Before you put the double clamp on for the second anastomosis, make sure the graft isn't twisted. If it is, this is your last chance to straighten it out. While you do the second anastomosis, keep the proximal single clamp on. You don't want to fill the graft up with a column of blood right now. If you did, it would probably clot. You can do the second anastomosis the same way as the first if you want to, or if you're ready for something more difficult, you can do it one way up. Remember with the one way up technique to put the body of the clamp and also the first and only stay suture away from you, so that you can put in those awkward upside down sutures easily from far to near. If you'd like to go without that blue plastic stitch holder, you can use this niche in the clamp instead. A cheap trick, but effective. With the far side completed, let's see what it's like to complete the anastomosis without a second fixed stay suture. Suture the front side from near to far, either pulling on the tissue to bring it tight, or pulling on the suture that you just put in as a handheld stay suture to keep things nicely stretched out. Now the second anastomosis is finished, it's time to take the clamps off. First, take off the double clamp, then the single clamps. With 2 anastomoses ready to bleed, you'll save some bloodshed by taking the distal clamp off first. Once the gentle back pressure bleeding has subsided, take off the proximal clamp, and the job is done. In clinical work, I hope you won't hesitate to use a vein graft whenever you think you need one. Remember, this works. This doesn't.
Interpositional vein grafting is done when a substantial gap occurs in a critical vessel. The standard practice model is done in the rat, placing a segment of the epigastric vein into a femoral artery gap. Here, the central portion of the common femoral artery has been cauterized, obliterating the lumen and occluding the vessel, which will necessitate resection and grafting. Clamps are applied at the extremes of dissection, here using 2 single clamps. In most clinical vein grafting situations, the gap is much larger than will be generated here. The cauterized portion is resected, removing about 4 millimeters of arterial length. Substantial arterial retraction may occur. The lumen on either side is irrigated with heparinized saline. The epigastric vein is dissected, then ligated at either end using 10-0 nylon suture. If the downstream end, the proximal end, is ligated first, the venous pressure may help to distend the lumen. This will facilitate subsequent irrigation of the blood from the lumen. A marking stitch should be placed at one end of the vein, driving the needle through the adventitia only so that the inner vessel wall is not violated. This marking stitch will allow identification of the particular end of the vein later so that any valves present in the vein graft can be placed in line with the flow. With both ligatures in place, the vein is cut at one end only.
The goal of this tape is to describe a step-by-step, clear-cut approach to performing microsurgical nerve repair in the rat sciatic nerve model. We recommend that the basic skills of microvascular surgery be mastered prior to undertaking the nerve repair outlined in this tape. The rat femoral artery and vein are well-known laboratory models for developing microsurgical proficiency. In the clinical microsurgical situation, frequently the nerve repair is performed last, after the vessel repair, when the operating team is the most fatigued. Attention to detail at this point is crucial, as the quality of the nerve repair may well determine the ultimate functional outcome. The sciatic nerve rat model can be as indispensable in gaining technical microsurgical confidence as the femoral artery and vein are for developing microvascular skill. There are three basic varieties of nerve repair: epineural, group fascicular, and fascicular repair. To understand the technique of nerve repair, basic nerve anatomy will be reviewed briefly. The epineurium is the outer investing tissue of the nerve and contains longitudinal blood vessels which can be used for orientation purposes. This is how the epineurium looks in the rat sciatic nerve. The internal epineural tissue, or interfascicular epineurium, connects the fascicles or fascicular bundles together within the substance of the peripheral nerve. The perineurium is the shiny tissue investing the individual fascicles. The endoneurium is contained within the perineurium. In an epineural repair, the nerve ends are aligned and sutured, attempting and hopefully succeeding at aligning the fascicular bundles contained within. In a group fascicular repair, the fascicles or groups of fascicles are themselves aligned and sutured. At the moment, the decision to perform an epineural or group fascicular repair is usually a matter of surgical judgment and will not be discussed in this tape. In this tape, you will learn how to perform both epineural and fascicular repair techniques. To begin, we will first review the instruments used in this technique, then go over rat preparation, superficial dissection, deep dissection, and then nerve sectioning and nerve repair. For this technique, the instruments you will need are a scalpel, ring scissors, Adson forceps, rubber band retractors, a number 5, number 2, and a curved jeweler's forceps, a curved micro scissors, a 15-degree angled micro knife, a tongue depressor or toothpick to use as a stage for nerve sectioning, background material, and Tenno suture. The rat sciatic nerve emerges halfway between the ischial tuberosity and the hip joint and runs straight out to the knee joint as shown in this rat skeleton. The rat is positioned in the prone position with the hind limb shaved. It is helpful to place the tail and a 3 or a 5 cc syringe underneath the leg being operated on to elevate the nerve. The important landmarks are the knee joint, the hip joint, and the ischial tuberosity. An incision is marked out from the knee joint to the ischial tuberosity paralleling the course of the nerve. The dotted line represents the course of the nerve. When making the skin incision, note that the skin is quite tough in the posterior area, and care must be taken to control the knife. The superficial dissection, without the aid of the microscope, consists of identifying the plane between the biceps femoris and the gluteus maximus muscles, as seen here. This plane is developed with the scissors, revealing the underlying sciatic nerve. Place the retractors beneath the muscle. From now on, the dissection is performed through the operating microscope. The nerve is gently freed up from the surrounding tissue with the curved microscissors. Avoid placing undue tension on the nerve. Upon close inspection, it can be seen that the sciatic nerve usually has 3 fascicular bundles, although this is somewhat variable. We will section the nerve in this area here, proximal to the splitting of the nerve. Notice the longitudinal blood vessels coursing in the epineurium. Take care to handle the nerve gently. Place the background material underneath the nerve, and you are now ready for nerve transection. Place the flat toothpick or tongue blade beneath the nerve with your non-dominant hand. With your dominant hand, grasp the microknife so it is perpendicular to the nerve. Then, in a smooth motion, press down on the wood and pull towards yourself, cleanly cutting the nerve. If you take a long time to repair the nerve, or if you are rough with the nerve, you will notice the axoplasm protruding or mushrooming out of the end of the nerve, which makes the repair more difficult. Now for the actual repair. Grasp a point on the epineurium 180 degrees away from yourself and pass the needle carefully, avoiding the underlying nerve structures. Carefully follow the curve of the needle to extract it and pass it to the corresponding part of the proximal nerve. Use the vessels and fascicles as landmarks for orientation purposes. Tie the suture in standard microsurgical fashion, but when pulling on the suture, pull towards the anastomotic area to avoid trauma to the nerve and to avoid mushrooming of the nerve ends. Cut the end of the suture with the needle short and leave the other end long for traction purposes. Note that it is easier to pass the needle through the epineurium in areas between the actual bundles as opposed to right on top of them, because in this way you are in less danger of spearing the underlying fascicles. The second suture is placed 180 degrees away from the first and towards yourself. For assistance, the background material can be used as a self-retaining retractor, or you can use the first suture to control the nerve. After the second suture has been placed, flip the nerve over and place a third suture halfway between the first two. When this is complete, again flip the nerve over, and usually one final suture midway between the two completes the repair. Note that the number of sutures used is the minimum number required to ensure approximation of the nerve ends. Now we will look at a fascicular repair. By carefully peeling the epineureum back, you will notice several fascicles within the nerve. These can be repaired individually with 10-0 or 11-0 sutures, followed by the standard epineural repair as follows. Place 1 or 2 sutures in each fascicle or group of fascicles. Once the fascicular sutures are complete, the standard epineural repair is performed. We hope that this model will prove useful in preparing you for clinical, microsurgical nerve repair. To review, the key factors for success are alignment, gentle handling, and a cooperative rat.